Minal?
You can share the link on the gas group also.
Yes, yes, yes.
Both the non-academic group and the academic group.
Non-academic, I'm not there, but Shiv sir will be doing the probably.
Okay.
Yeah.
Okay, guys, going live. Okay.
Minal?
Yes.
Yes, yes, yes.
Both the non-academic group and the academic group.
Okay,
Non-academic,
good
I'm
morning.
not there, but
Good
Shiv sir
morning.
will be doing the.
Good morning,
Okay.
everyone.
Why voice?
We are actually starting off the leap series. This is
Minal?
Yes.
so today we are starting off our the life leaf series or long life leaf series, and this is learning from experience and adapting for the future. This series is related to airway and breathing, and would include case scenarios which will take us through from the time of the preoperative assessment to the extubation phase and postoperative phase. The series has this first series is being hosted by Dr. Minal Chauhan. She is the host and the organizer of this, and she's done a lot of hard work. And from selecting the cases, talking individually to the faculty, and she was mentored by Suchitra, so she's the co-host and the mentor. And during the organization, we need someone to look at what's happening, and Chetna will also be our co-host, looking at and spotlighting others and stuff like that. So looking forward to a very interesting and interactive session. And with this, I'll hand over to Meenal. Meenal, over to you. Meenal and Suchitra, of course.
A very good afternoon to everybody. It is an extreme honor for me to be organizing this event today. And I would like to share my presentation with all of you. Yes. So this is the first of its kind, the LEAP series, which actually stands for Learn from Experience and Adapt for the Future. When we began brainstorming about it, we thought it was going to get, limited only to the freelancers. But we slowly realized that all of us, be it those working in corporate, medical colleges, seniors, juniors, all of us need to learn from experiences and keep adapting. Flexibility is the key. I would especially want to thank Dr. Shiv Kumar Singh. Dr. Shiv is the brain and everything, the heart brain behind this series. And he's the one who actually catapulted us into starting something like this. So Alvin Toffler said that the illiterate of the 21st century are not those who cannot read and write, but those who cannot learn, unlearn, and relearn. You know who is Alvin Toffler? He's the father of modern digital revolution. So because of him, you and me are sitting, across one panel and exchanging ideas. So it's very necessary for all of us to keep improving our knowledge. Now, Airway, the first and the foremost series we jotted, we had a lot of brainstorming sessions and then we decided to come with the Airway series. Sir Macintosh said that three ingredients of a good anesthetic is a good airway, and a good head. Even if you're into regional anesthesia, you still have to have all your paraphernalia ready for a good head. It is our bread and butter. We are absolutely obsessed with it. We are experts in the air. We are supposed to be experts in the air. From looking at the patient during the pre-anesthesia checkup, we pick up a lot of pointers which can suggest that it may be a difficult airway. We assess, we plan accordingly. But many a time, a very an airway which looks absolutely harmless can lead to a nightmarish situation. And that is where all your skills, extra learning, algorithms, flowcharts, and a composure of mind a good mental health, that is where I would say comes into picture. Along with that, we would also take you across a lot of different scenarios in this symposium. It's more like a CME in which we learn from a lot of people, be it bronchospasm, laryngospasm, extubation, etc., etc., etc. So as we go forward, we keep discussing it. So today with us, we have an esteemed panel of people who would be talking about airways. To begin with, Dr. Raghavendran K, who is Director Anesthesia and Pain Services at SIMS Hospital. And we all know him very well. He's an institution in himself, from sharing cases to connecting them to life stories. Dr. Shiv Kumar Singh, of course, the consultant anesthetist from University Hospitals, Liverpool, with special interest, I would say special interest is in the entire anesthesia. He loves anesthesia. He breathes anesthesia. He's into education, training, teaching, calling, helping. Thank you, sir. Can't thank you enough. Dr. Suchitra Nikam, who's a consultant freelancer anesthesiologist from Pune, a very effervescent, bubbly person. We have seen her presenting a lot of regional anesthesia cases on the gas group, and she has 30 years of freelancing practice to back her with a lot of difficult cases and scenarios which she can share with us today. Dr. Soma Ganesh, Associate Professor in Sri Ramchandra Medical College with a special interest in airway. You can find him very soft-spoken, demure, quiet, but he's a powerhouse of knowledge. Aggressively, he can impart that knowledge. So these were the panelists, and now we come to how are we going to go ahead in this particular symposium. So we have handpicked a few cases, and we have a few presenters who will be presenting it. Not necessarily they have done it, maybe they have been involved in it, maybe they have helped a group of people. And I would also want to say that this is not to bash or shame anybody. This symposium is to learn from all our mistakes, or maybe no mistakes, we're just learning new techniques. It is not about criticizing anybody, but why was this not used or why was this used? Everybody has a different way of doing it. The main purpose is the safety of the patient, and if you are able to deliver what you set your foot on. So coming to the presenters, we have Dr. Dilip Kumar, who is from Mumbai. He's a freelancer anesthesiologist, and also he's done a degree in LLB. Wow, sir, welcome. Dr. Mirza Beg, who is he's a specialist anesthesiologist from Riyadh with special interest in pediatric anesthesia. Got the good chance of interacting with him, a thorough professional and a very fine gentleman. Dr. Chetna Agarwal, a freelancer anesthesiologist from Vadodara with a fellowship in pain management and very active culturally. Dr. Jayal Bhagat, a freelancer anesthesiologist from Surat with special interest in pediatric anesthesia, has also done a fellowship in pediatric anesthesia. So, and this is me, your host for the evening. I'm a freelancer anesthesiologist from Roorkee. Besides anesthesia, my interest is in mental health and well-being, and I'm pursuing it with a lot of momentum at the present. So let's talk about airways. Now, not all airways are created equal, and that is very, very obvious to me. So let me, there has to be an analogy between airways. I always feel that we anesthesiologists and the airways, we have a relationship. We have a relationship of love-hate at times. You know how it is between a husband and a wife. So let me take you through the stages of this relationship. The first stage is that stage of romance. When you newly enter the med school, like you're in your first year of PG, and airways are something that's very fascinating. You are cleaning them and gelling them and preparing the airway cart, etc. The second comes the stage of tussle, the power game stage. When you actually intubate the patient, you're trying, you think it's a good airway, I've done all the assessment correctly, but then you land up in Cormac Lehan 3 or 4, you're not able to see. It's almost the airway teasing you. Come on, baby, try me. Come on, let's see. It's something like that. And then you come to the third stage. The third stage is that of stability. You see, you have started mastering a few techniques, you have a few other equipments in your cart. Then comes the stage of commitment towards your work. When you start realizing, okay, this is not enough. I need to keep learning. Maybe a video laryngoscope, maybe fiber optic. I need to attend seminars. And then, of course, you come to the stage of co-creation, which is what all the mentors are doing here, all the panelists are doing here. They are all airway experts. They are actually here to teach us, guide us, discuss, share their knowledge, their rich knowledge. So, with this background, I would like to begin with today's first case. Now, this first case was actually, given to me by one of our own group members, but on conditions of anonymity, I would be continuing to tell you the case. It talks about every little aspect of freelancing, let me tell you this, from beginning to the end of freelancing. It also tells that though we make mistakes, but if we learn from them, it serves as a pedestal. It serves as a, for others to improve. This wisdom is enough for others to improve and not make those mistakes again. So beginning with the first case for the evening. A young 34-year-old male who was ASA grade 1 was taken up for liposuction around the umbilical area. She got a call about 2 hours back. It was a small setup, a small nursing home. She though knew the doctor but had not worked enough with the surgeon. She reached there and did a bedside PAC. A very quick assessment of the airway was done. Decided to give subarachnoid block for a 3 to 4 hours procedure. Subarachnoid block was given along with clonidine, but a few droplets of it did fall. But she went ahead with it. About 1 hour into the surgery, the action wore off, and the patient started complaining of pain. So GA had to be given. She wanted to put in a tube. So the first attempt was done at laryngoscopy. Couldn't see anything. Cormac Lehan grade 3 or grade 4. Second attempt was done using a McCoy blade and a Bougie. Still nothing could be seen. By then, damage was enough. Cords were damaged. Bleeding had started. For the third attempt, somebody was called. Somebody came and did a proper endotracheal intubation. Again, with a lot of difficulty. Cylinder was attached, the oxygen cylinder, but it lasted only for 15 to 20 minutes. And after that, the patient actually went into hypoxia for lack of oxygen. They kept searching everywhere, they couldn't find it. There were arrhythmias, there was cardiac arrest on table, they couldn't revive the patient. By the time the patient could be shifted to another center, he was declared bronchial. Now, this is something I think most of us don't want to share with anybody. But I would thank the person who has done this. It has given us various points to improve and things to talk about today. After this case, she actually went into a lot of mental trauma. For nearly a year, there were litigations in and out of police stations. The practice was not, building up. It's been 6, 7 years to that whole episode. Things are fine, but it took a long time, affecting the mental health as well. So this case serves as a template for all the freelancers working out there who want to begin their freelancing practice. My first question thus, I would want to ask Dr. Suchitra, ma'am. She is a seasoned freelancer. Ma'am, what do you think are the points, or what do you think are the things which any budding freelancer should keep in mind before they start practicing, especially you know about this scenario? You can unmute
Yeah.
yourself, ma'am.
Yeah, and Minal, you can stop sharing the screen so that we can actually see the speakers now. Yeah.
Yeah, thank you, Meenal, for the beautiful presentation of the case. First, I would like to pay my full sympathy to the anesthesiologist who did this case. Anyone can go through that scenario. And now we have to learn that what shouldn't have been done and what precautions we should take while doing the freelance practice. At the onset, actually, I'll go through briefly because we have discussed all these points in our previous symposiums on freelance practice. So I'll just go through briefly. First and most important thing is while starting your practice, when a new freelance practitioner should go slowly and steadily. we have to, at the onset, we have to choose our cases very carefully. Here, the patient was posted for, this particular case was posted for liposuction. So maybe the patient was obese. Obesity itself is a scenario, the alarm bells should start ringing about difficult intubation, and we have to take all the proper precautions, that if at all, even though it is a subarachnoid block, are we ready to intubate if there is some emergency. So most important thing in our freelance practice is choose the cases wisely. If at all you are new with the setup, you try and go, first try and go and see the setup, know the details about your surgeons, whatever OT assistance you are going to get, and try and keep whatever things you can carry. You see, you can't go and develop the difficult airway cart at each and every new place. It's very difficult. You can't just do it. So at least you try and develop your own kit. Like you can keep all the endotracheal tubes, you can keep ambu bag with you, you can keep the routine laryngoscope with all the bloods with you. Then we can carry all the emergency drugs, because many a times it can happen that you can't find emergency drugs also in that particular setup. So atropine, adrenaline, all the things you should carry with you. And these are a few things. Some common supraglottic airways, like common eye gels, you can carry, because those are very easy to put. So you can carry those things with you. So that precautions you have to take. Then I learn to say no. If at any time, if you are not confident that you may not be able to do the case right after seeing the patient, if you think that you won't be able to do the case properly, then you just be frank enough to say no. Because if there is any mishap at the start of your practice, then your career is ruined forever. So you have to learn to say no in such situations. And you try and learn new skills. Like there are different airway workshops. Whatever you have learned in your residency or in your while you are doing your PG, that may not be enough. There are many new things coming. So you have to update your knowledge, and confidence comes with perfection. You have to be confident, but that confidence it comes with perfection. So excuse me. So these are some of the precautions we have to take while starting. And don't pay attention to the monetary gains at the start of your practice, because patient safety is the most important thing. You not get a good money at the start, but if there are no complications and if you prove yourself, then slowly your practice starts building up.
Yes, ma'am. Anything else you would want to add to it?
I think, yeah. And for the high risk cases also, high risk cases, there is, it's good to have a group practice. We can come to it later, but if you have someone to help, either you form a group practice or you call for help in time.
All right. So I think here it's very, very clear that you don't have to please anybody, which is what the young freelancers have to take away. That we don't have to please anybody. If we know something, we know it. If we don't know it, we take help. If we can't take help, we stay at home. That is something. So my next question I would want to ask Dr. Soma actually, how do you think there was some error in judgment? It's not just this case, but in general, there was some error in judgment when there is a case which is scheduled for 3 to 4 hours, and then we are planning to give subarachnoid block. So, you think we should know more about the case?
Yes. So, there is nothing called right choice or wrong choice of anesthesia for liposuction. Liposuction has been done even with sedation, with local anesthetic infiltration techniques, and with spinal anesthesia, epidural anesthesia, and general anesthesia also. So it depends upon how obese the patient is and how what is the infiltration that they are using, the tumescent anesthetic technique, whether it was a dry technique or a wet technique or a super wet technique. So I probably presume that the surgeon has infiltrated.
He has infiltrated xyloadrenally.
Yes.
It has been increased.
So I presume the tumescent anesthetic technique has been used, supplemented along with spinal anesthesia. So it's quite okay, because with spinal anesthesia and supplemented with tumescent anesthesia, the tumescent anesthetic technique will take care even if the patient is having pain, if an adequate volume is being introduced. So I have a couple of clarifications needed with the information you have given, because with all the anesthetist has taken some history, and history has been taken, and spinal anesthesia has been given. But when the anesthetist has intubated the patient, and an oxygen cylinder was brought in and the oxygen has been lost. So uh, a little more clarification is needed whether an anesthesia machine was there before anesthetizing the patient. So that's one of the important things we need to look into it before anesthetizing, especially in a freelancing setup, because an anesthesia machine, if there is no anesthesia machine, I feel even if you're a freelancer, you should say no, even if you're going for as a standby anesthetist for a local procedure or a procedure under MAC. That is an important thing as a starter, starting for a freelancer, we have to keep in mind. And the backup for, or as Suchitra ma'am has told, we need to have a backup for a plan A, B, C, D for a difficulty airway, whether it is an anticipated or an unanticipated difficulty airway. What if our primary technique or a plan A fails? What we are going to do next? So that has to be kept in mind, even if we are going to do an surgery under spinal anesthesia. And being a freelancer and having done this case, and though the patient was not was intubated a third attempt, I believe till the third attempt, the patient was being ventilated properly. So I don't think the hypoxia has happened because of that. The hypoxia has happened later because the patient was not able to be, so the supplemental oxygen was not being obtained from the hospital side. So I think we are working as a team in anesthetizing a patient. So a surgeon, anesthetist, and the management of the hospital, all are responsible for such an event. So we cannot just blame an anesthetist for this procedure, though the anesthetist has to take responsibility for not checking the oxygen backup before anesthetizing the patient. The cardiac arrest could have had so many reasons, like if the tumescent anesthetic has been used, some 45 to 55 milligram per kg of lignocaine has been infiltrated. It could be a local anesthetic systemic toxicity, or we have no idea. It's an AC. We presume that the patient is an AC1 with a history that has been taken, and underlying concealed cardiac problems like a dilated cardiomyopathy or something else could have been there, and the local anesthetic could have depressed the myocardium. And with liposuction, we tend to overload the patients with fluids. So a fluid overload, a pulmonary edema, so many things can happen even within. Liposuction is one of the procedures in a high risk. I consider all patients who are undergoing high liposuction as a high risk patients. With the added obesity and underlying problems that the patient may have, a GA could be considered as a gold standard, but I don't think spinal anesthetic is the wrong choice. So we need to know the amount of fat that has been taken, how many liters of fat has been taken out, and what is the duration. I think we need to discuss such issues with the surgeon before anesthetizing so that we can have a definitive plan. And yes, before anesthetizing a patient for liposuction, forget about liposuction, any patient for spinal anesthesia, we need to have an anesthesia machine with a backup of oxygen cylinder. I think the basics of our first year teaching, the moment we enter residency, the first teaching will be like to check your backup ventilation amber bag. Then we check the anesthesia machine and check the cylinders and check the backup cylinders. And then only we will start even loading atropine and ephedrine or so any other drug. So I think we shouldn't forget basics before proceeding further. That's what I want to emphasize. And one more thing is that adrenaline has been given. So the dose of adrenaline that has been gone in, that could have been an effect on the patient's hemodynamics to have an adverse effect. So many factors are there to have a cardiac arrest, not just lack of oxygen. Maybe because the difficulty in difficulty in intubating and oxygenating could have been the pinnacle of the adverse events. It's the classic Swiss cheese pattern that has so many concealed factors were there, and just a momentary hypoxia has precipitated this event. That's how I see this.
Right. So you would want to say that this is just the tip of the iceberg. There are many other things which could have been the underlying factors. And of course, to just clarify, there was a machine there, of course, but the cylinder, the oxygen cylinder actually went away. So that was one problem. They couldn't check, they couldn't get. But of course, as you said, there are so many vital points to be taken away from this that liposuction by itself is the surgery which should be taken care of, and you are supposed to treat all your patients with a lot of, you are supposed to, they're high risk patients. Right, sir. Thank you for your input. Now I would like to ask Dr. Raghavendra, sir, that, okay, now in this particular case, actually what happened is that from the time the patient was taken inside and the anesthetist was a very young person, the surgeon was uh, old enough, the patient's relative was inside the OT during giving spinal anesthesia, and when all this happened. And because the patient's relative happened to be a medical person, he didn't want to leave. So that is another thing which she felt pressurized. So what is your take on letting patients relatives be while induction, and what do you practice?
Thank you, Dr. Minal. Am I audible? Okay. See, a very unfortunate event has occurred as far as patients concerned. Young patient undergoing not a very life-saving operation has gone for a problem and then slipped from a grade 1 ASA status to grade 6, or even lost his life. Okay. So, and I think it's happened with a person who is in the early part of his career. Really taken away his confidence, to do further case and all. And I think probably, there should be some experience which should come into the picture, because what I feel is that people who have just finished their, the education, MD level, whatever equivalent levels, they must take some time to spend with a good senior person, a mentor, for a period of at least 2-3 years. Till such time they become confident before they venture into private practice. Because giving anesthesia in a private setup with the limited resources calls for a lot of judgment and then skills and expertise now. So I think probably they didn't take into account the basic facilities which are available. And secondly, I think regarding and there should be some sort of escape plan which was probably not there, and then a panic situation has occurred, and then probably they're not able to go further into the thing, and the presence of a relative in such a situation adds to the problem. What I feel is that I think even if it is medical personnel who is inside, I think there will be a lot of inhibitions now, especially when you're dealing with some first time you're dealing with a patient and complications occurred, and then they're going to watch everything. Is going to put some pressure on you in addition to whatever his patient is undergoing actually. So probably, I think we could have stopped that one, and then one way it's okay. Let's see, they all know what's exactly happened, and but it also leads to a lot of conclusions about the status of the hospital, how inadequately the hospital was equipped, and then the surgical skills they exceeded their limits, and then the anesthesia was not adequate, and then they couldn't get into the plan A, plan B, nothing could be executed, and then the oxygen, which is so essential, could not be provided. I think this is all situations which could be totally avoided. I think feel sorry for the patient and also for the anesthetist. I think probably a little bit of immaturity is in that. And I think what I feel is that unlike surgeons who have got more time at their disposal, so you can cut the aorta, you can cut major vessels, you can pack it up, have a cup of coffee and come back. Patient still be alive. But you've got only about 3 or 4 minutes time in which you have to act fast and then put in a tube or sedate the patient. If something happens in limited setup, then God help you. That's what has happened here. I think probably you have to use some discretion, and unless you're totally confident, even then what I feel is that in my setup, if I have to allow a medical personnel or someone who is who wants to stay inside at least for induction, I do allow them after getting a permission from the concerned authorities and all. But we always advise them that their presence is going to add to some sort of inhibition from the surgeon. They won't be able to act in a very rational manner, and there'll be some inhibitions and decision taking may not be proper. So I'll ask them, okay, just stay there for induction and go away. That's it. That's what I tell them actually. So that's what we always advise them, and then they also comply with that. And then we tell them, only person whom I allow to induction is probably parents. for children, because the parental presence during induction really helps them. And then once the child is induced, you ask them to go immediately out. So it will become a very traumatic experience for them also. Thank you.
Yes, ma'am, you want to say something?
I agree totally with Dr. Raghavendran, because there are pressures. So unless and until the person is anesthesiologist himself or the relative, then it's better not to allow that person to come inside, because doctor is a very broad term, and many may perceive the things going in a wrong way, and they may come out in a wrong way. So it's better not to allow. Just politely tell them what are the problems. The infection chances are also increased if the person is inside the OT. In the freelance practice, mostly the OTs are small, so naturally there is less space to go around. So we can just politely refuse.
Correct. So basically, I want to tell all my young freelancer friends that please don't get intimidated by the surgeon. You are supposed to. You can take a stand for yourself, and if you are not comfortable in letting people stay inside, no matter how young in practice you are, you can always say a no. So, my next question, I would like to ask Dr. Soma actually. Dr. Soma, um, you know, um, our anesthesiologist went through a lot of issues later on after the whole case. So the importance of professional indemnity. See, a lot of corporates, they have made it compulsory for us to enter or join. Like I was not allowed to join till I didn't have a professional indemnity, but nothing like that is there in freelancing. So can you just talk about it?
Yeah. I think professional indemnity is important for all doctors, and it's much, much more important for anesthesiologists. Though it's like even if we earn very limited amount of money, but then when it comes to someone putting a lawsuit against you, we will be losing quite lots of money. There is a Supreme Court. If you go to the Supreme Court website, we can see that only 10% of cases that has been put against anesthesiologists, they are all real, true cases that needs negligence, that is real negligence, and that needs rewarding the money. But the rest of the 90% are all fake cases that's just put against anesthesiologists. At every stage of anesthesia, we are at risk of getting sued. It may not be negligence, it could be an error of judgment, or it could be such that the events they go spiral downwards in a faster way, and we may need hands, and especially in freelancing setup, if another hand is not present, then we are actually crippled. Especially when there is no ventilator, you are hand ventilating, your patient is going in for an arrest, or you have to resuscitate. Even if in volume resuscitation and chest compressions, there's so many things that comes in into play. So I think every anesthetist should have a professional indemnity so that they can face the lawsuit. It's like the American closed claims states that around 45% of patients who were in PACU, where the patients in PACU had sued the anesthesiologist. So 45% of patients in PACU for poor quality of care. That's what the data says. So if such situation exists in India, it will be very difficult for us to practice. So I think everyone should have indemnity. We may face some unforeseen lawsuits, and then our entire morale will go down. One, with the loss of patient, and the other, there are certain cases where patients have had an hypoxic ischemic insult, and they were on ventilator or in a vegetative state for a prolonged duration of time, and then the anesthetists were forced to take care of the medical expenditures of such patients. So it's pretty difficult for a freelancer, especially as a newbie who has started his practice just now. So I think everyone should have a professional indemnity insurance. Nowadays, it's pretty easy. You have lots of, if you Google, you can get it through online. I think Indian Society of Anesthesiology, they have the cover you. The web page of ISA, they do have access for applying for professional indemnity also. So I think it's we will be in a sort of guilty that we have done something wrong, and our entire morale goes down. But then the patient or the patient's relatives will not be in such a situation. They will be taking an upper hand and trying to get money from us. So I think having a good amount of professional indemnity actually rescues us from such a situation. And with good psychological and moral support from seniors and other people, I think it's easy for an anesthetist. It's not easy, but the anesthetists can come out of situation with a lesson well learned.
Right, so that
Thank
was
you.
very well. Yes, ma'am.
And we have income tax benefit also for that. So taking professional indemnity is a must. You are a freelancer or institutional
Great.
person.
Fine. So I would just like to share with you all that what exactly happened in that situation. So when I was speaking to her, she told me that whatever she went through, and then sorry, I have a few things to share. Yes. So what were the steps taken post that critical incident? When I actually spoke to her about it, she said she actually learned the video laryngoscope. She learned how to use it. She also learned how to use fiber optic bronchoscopy, did a proper course. Then started investing in group practice, calling like-minded people together. And regular meetings were held in that area to discuss all the critical events. So this is something which actually was started by her. So here I would like to ask Dr. Shiv actually, that sir, could you tell us a little bit about video laryngoscope and the learning curve of that instrument? And how important do you think it is now to keep a video laryngoscope?
Sorry, Minal, was that question for?
For you, sir, it is video laryngoscope.
Sorry. I thought it didn't actually add that. Okay.
Yeah, it is for you, sir.
Yeah, I think video laryngoscopes are actually becoming important. One of the things is that you need to get used to a particular kind of, it doesn't matter, there's no best kind of video laryngoscopes, right? So whatever is you actually get hand on, you try to actually, whether you can actually obviously choose that from going through workshops where they have display of a video laryngoscope, and you buy whatever is suitable for you and get used to it. So don't just use it for emergencies, use it in some routine cases as well. And if the most of the video laryngoscope obviously come with a screen. So what it helps is that if you actually have got someone who is around you, they can also see what you are actually the problem you are facing.
Correct.
And video laryngoscope is also part of the difficult airway guidelines, unanticipated airline. So you need to actually use it. So have it. It's a very, very useful tool.
Yes, it's not very expensive also, sir, as far as
Yes.
I believe. A lot of
The
them.
cost have come here. Yeah.
Yes.
I mean, in UK, we tend to actually use the disposable ones. You actually have the video laryngoscope where you can actually just have a plastic sleeve. And some of them, like the air track, you just use and throw. But we're trying to reduce that use now because there is actually increased cost, but you can have a better kind of scopes. But I think in India, a lot of people tend to use re-sterilize them and use them.
Yes, that is what is happening. Right, sir. So now I would like to ask a question to Dr. Suchitra, ma'am, because you're into freelancing for a very long time. What do you think about group practice, especially here in this situation?
Actually, yes, group practice is a very good thing. If you are ready to share the monetary gains and if you don't have any ego problem, then it is a boon, definitely. There are many advantages. The most important is the risk is shared. If two or more go to a case, at least two, if you go to a case, then definitely the risk is shared. In freelance practice, many a times we don't have a trained OT personnel to help you. So if you have an anesthesiologist with you, then definitely that is going to increase the safety margin, whatever is the case. Then we can cover many hospitals as a group. We can cover many more hospitals, and that also adds to the monetary gain. Then we can have a paid holiday. In freelance practice, we don't have otherwise that luxury. If you are not working, the monetary gains are zero. So if at all, if there is a group practice, turn by turn, we can take a holiday, and that can add to the well-being of the anesthesiologist. And but more advantage is that in emergency, many a times if you call for help, then the expert help may not be available on the 11th hour. So if at all you are in a group practice, then there is always someone to cover you. Someone is available to cover you, and that person can reach to your help easily. So and different people in the group have may have different skills. So together we make a good package. Say I may be good in regional anesthesia, someone will be good in the airway handling, so airway procedures. So someone will be in sort of doing, I don't do much of the intensive care procedures. So some anesthetist in my group may be good in that. So collectively, we got a good package, and that gives a good patient care, and the surgeons are ultimately satisfied. So it aids to the freelance practice, a group practice.
That's a wonderful point which you've got. So, Vasa, is it now audible? Am I better?
Yes.
Is the sound now better?
Yeah, you're better.
Okay. Yeah. So yeah, that's a wonderful point which you have put forth, ma'am. Actually, most of us are into, we don't really, take the help of anybody else. We have too much of ego. I think here, this is the time, low resource settings. There was a very good article on low resource settings in 2009 in Anesthesia Journal also. And actually, it defines the low resource setting as something which works on lack of equipment, infrastructure, manpower, everything. So if we do have a team which can actually correct us and tell us and help us, and it really helps in a large amount. So here I would like to say that so this is where the presentation, I'll just take you back to it. So here I would like to say that what are the takeaways in this particular case? Okay? So the takeaways are PAC is a must. Whatever the case is, a PAC is a must. Preparedness is the key. Don't get overexcited. Gather enough knowledge about the procedure. Freelancing kit, which, as ma'am has told, thorough check of the machine equipment, and any case which requires a GA. You don't have to assume this is only going to be a regional. You have to keep yourself prepared for every GA. And it is also important to have all resources to execute plan A to D. As Omar said, we need to have various plans, and we have to have those resources. Right. So next, I would like to ask a question to Dr. Raghavendran now, sir. That in this, but do you think sometimes when people end in difficult intubation scenarios, unanticipated or anticipated, whatever it is, do you think the assessment is not enough? And would you want to point a few special things which they should actually keep in mind while assessing the airway?
Yeah, thank you, Dr. Minal. Okay, yeah, you have to have some sort of, some way of examination with reference to airway also when you do a PAC. And certain factors will be glaring at you. See, someone who has got a obesity and a thick neck, and then a short muscular neck and all, and then dentition, etc. Those things are quite obvious. But many times we get caught in an unanticipated situation. And that's where our plan A, B, and everything comes. But I think what I feel is that certain procedures, if you anticipate, then you can go for some other radiological investigations as well, like X-ray of the neck, and then any previous history that should alert you. And then one history which you can always elicit is, say, any not just difficulty, because people may not know what exactly happened during anesthesia. Only thing they'll say, they took some time to come out of anesthesia. So that is when they're sleeping for longer time and all the 6 months. So those things should alert you. And then certain genetic factors actually also play a part. They say that sometimes they take about hours, in scolding apneic patients and all. So those history is very important. And then do a thorough PAC, and that should alert you. An astute anesthesiologist who can do routine airway checks can easily pick up most of the obvious problems and all. The problem comes when it is unanticipated. Okay, so that's when we have to have something like a mental plan or a plan A, B, and all these things. Now, I think here only you have all this training comes. Something like a lot of places in the West, they have what's called a simulation-based learning process now. So if you come across a situation like this, what do you do next, like that? So that they have definite plans. Then you got algorithms are there from most societies are advocating this plans of actions and all. So go through all these things and, all, and get familiar. And then when you go through some simulation-based learning, it is in your mind. Okay. And once you have, and what I feel is once you hold a mask and ventilate the patient with after giving a induction agent, you will know by just by feeling for the airway and by extending the neck itself, you'll know whether it's going to be difficult, not difficult. Okay. So you will have an idea. Then immediately the preparedness should never be left out. Always it's there, always. And then have a trained help. And then for younger people, they should have someone to have as a backup anytime. Okay, so they should be around to help them out now. So I think this kind of preparedness probably can pick up most of the things now. And then worst comes if you have some this anticipated problem, go for a shorter acting relaxants. Don't go for paralysis if you think there's a problem. And best recourse or safest recourse would be just come out before you could do any further damage. Now. Okay, just abandon the procedure. Let him come. Suppose you give succinylmetonium, allow the patient to wake up and then come out of it. Now, so you can always go back on the technique and then analyze the problems and then chalk out a plan of action in for the future. Anesthesia for such patients.
Right. So you're saying that we should also know when to stop. It is not just knowing to proceed with the case, but also when to stop, when to actually take a step back, right, sir?
Yes.
Yes, right. So now coming to, we keep, having these problems all the time. We face these difficult airway intubation problems all the time. But then what is it that we actually do about it? So this is the second case which I would want to discuss here, which has actually been done by Dr. Bougie. I will just give a brief overview. A 55-year-old male was taken up for septoplasty, ASA grade 1. I also have to tell you all that this case was done at the pre-Mallam Patti era, about many years back. The patient was a COPD and a smoker with repeated chest infections. He again had this problem of unanticipated difficult airway. So, Dr. Dilip, my question to you is, what steps were taken? What did you do next? Hello, Dr. Dilip. If you could unmute.
Can you stop sharing the screen? Let the people come in. Yeah, I will. Where's the lead? Where is he gone? Yeah, it's not. I think we.
Okay, I'll do something.
I think he's got disconnected. So shall we move on to? Yeah.
So sir, we can have the difficult. Okay. I have another case here. I have another. Yes, sir. Sorry.
We can actually go on to the unanticipated difficult intubation,
yes.
and we can come back on the thing.
On this case, right?
Yeah.
So
okay.
we will go on to the unanticipated difficult.
Yeah. So I will. So we'll be talking about the guidelines. I think guidelines are very, very important, and unanticipated difficult airway can be quite daunting for people, especially here, like freelancers who are working on their own. So there are actually the vortex system, which is by the Australians, which is a simple way. So it's showing like you're going spiraling down. From A to D, and A is obviously what are we going to do? That's intubate the trachea. B is basically using a supraglottic device, and C is if the supraglottic device fails, then you are back to the face mask, based to the basics. But the Difficult Airway Society guidelines from UK is similar, and it has goes through Plan A to Plan D. So Plan A is what we normally do. We do a laryngoscopy, you succeed, you got the tube in, you just check with enteral CO2 auscultation. That's fine. That's what we are expecting to do. But what if you fail to actually intubate? the trachea. In that case, you go to plan B, and plan B is basically to maintain oxygenation. You actually insert a supraglottic airway device. And if you are able to actually get a supra airway glottic device, and this is the time to stop and think, okay, because you have got oxygenation in, you are maintaining anesthesia, and then you have to decide whether we need to wake up the patient. Do we need to intubate the trachea? I mean, the surgery is urgent and you need a definitive airway, then you can intubate through trachea. Or there might be surgery, may be actually a short procedure, but equally urgent, and then you can actually say, let's proceed without intubating the trachea. And the worst of worst, then you can actually go for a tracheostomy. That's if the case, it's a emergency situation or emergency case, or somebody who actually has got a extensive surgery, or you do not actually have any device to intubate through the supraglottic airway device. You don't actually have a fiber optic scope, you don't actually have the entry catheter, then you can actually do that. But if you're unable to actually get a supra airway glottic device in, okay, so you tried, you failed to actually get, and now the patient is spiraling down, then you're back to basics. You need to just say, fine, okay, we'll come back to face mask, So you get the face mask in. You might actually have used a long-acting muscle relaxant. In India, Sugammadex may not be available, but if you're in UK and you use rocuronium, you can reverse the neuromuscular blockade. But otherwise, you might actually have to then wait till the neuromuscular blockade starts wearing off, and then you can actually wake up the patient. But if you are not able to actually even maintain oxygenation using a face mask, then you actually are landing into the can't intubate and can't oxygenate situation. It was called CIVO, but it's now CICO, can't oxygenate. So it is the critical thing is about oxygenation. So the philosophy of unanticipated difficult intubation is two. One thing, you need to maintain oxygenation at all times. And second is you need to prevent traumas. So there is actually saying how many times will you actually do a laryngoscopy, okay, or a different laryngoscopy. So once you actually have ensured that first time you fail, you have actually ensured that the patient position is fine. So this actually goes into a little bit more details. So when plan A, you need to make sure that your neck position is good, and you need to actually, if you're applying cricot pressure, you might need to actually release that a bit, use external laryngeal maneuver, they call the burp procedure. So those things are there. And then you need to actually, maximum of 4 attempts, no more than 4. So because the number of difficulty you have, you start actually having, more trauma. You don't want to create trauma in that situation. Then coming to the that is the plan B, using supra airway glottic devices, it's better to actually use a second generation devices. So something which has actually got a gastric port or a channel. This is important. I've already discussed, this is the point where you will stop and think. You will get the whole team, you get the surgeon in, get the whole team in, and then you decide. Okay. And again, face mask ventilation is easy. So this is actually from the very beginning, you actually know. If your initial face mask ventilation has been difficult, you know that you are going to be in trouble. And for the plan D, now we have actually moved away from doing needle cricothyroidotomy and stuff like that. It is actually a scalpel cricothyroidotomy. And so I'm going to go through a little bit onto this. This is what people actually feel scared about. Okay. So that was actually just highlighting when you need to stop and think and when you will actually wake up the patient. So unable to intubate, unable to oxygenate, you got a paralyzed patient, and make sure the patient has got anesthesia, because otherwise there is high incidence of awareness, and you actually moved on to the front of the neck. Okay, so you need to continue maintaining oxygenation. You ensure that there is adequate neuromuscular blockade, then make sure the patient head is extended like you would do for a cryotherapy. So here we use just a number 10 blade, scalpel blade, you actually do something called the laryngeal hold or laryngeal handshake. You feel for the cricothyrotomy. Okay, you need to actually have a bougie, so you actually make a neck, and then you make a neck horizontally, then twist the blade with the sharp end facing down towards the foot, and then you push it laterally, so create a space and put a bougie in. Okay, and once the bougie is in, then you can actually thread a size 6 normal tube, okay, over it. So this is actually important thing. You need to actually know the steps. Most of the times you probably won't reach this stage, but if you reach this stage, it's better to actually practice this. You can do that. You can create your own mannequins and actually do it. And other important thing is that you need to actually have, we did actually talk about this is not possible probably in new setups or in freelancing. But if you can actually create a, your plan A, B, C, D, so that kind of a trolley where this is what I'm going to do. So you already have plan A and plan B. There's always tubes and video laryngoscopes, different size of laryngoscopes, and supraglottic devices. Face mask is already there. So most of the other things which are left is actually having a fiber optic scope, if there is a point, and then having an entry catheter to actually have that. Okay. This is just showing the entry catheter with it is threaded over a fiber optic scopes. So now you can actually get these portable, as is disposable fiber optic scopes. So sometimes it might be useful to invest in this. And you can actually see the trolleys with various gadgets. And now we actually have changed over. These are different kind of bougies. Okay, you need to be sure that it is a entry catheter, which is different from an airway exchange catheter. They are totally different things. Okay, and like I've said, trolleys, plan A, plan B, everything actually on that. So that's only, I think, more advanced thing. Okay, I think I'll stop sharing here.
Yes, sir.
Any questions on this or any suggestions?
Is there anybody else who would want to share something, some pearls from any of our panelists? Okay, so I'll just move ahead then.
Yeah, Dr. Dilip is actually
Yes,
back. I think we can actually get him on too. So we
Yes.
actually move on to the next case. Yeah.
Yes. So, Dr. Dilip, before you just left, I think there was a minor, there was a minor error in the network. Thank you for bearing with us, everybody. And I will have to, give a big round of applause for the YouTube audience. They're giving us a live feedback where voice is concerned, people are leaving everything. So thank you so much. All right. So Dr. Dilip actually did this case many years back. This was the pre-Mallampati time. He was a 55-year-old male who was taken up for septoplasty ESA grade 1, but a known smoker, COPD with repeated chest infections. When he went ahead, he fell into the trap of unanticipated difficult airway. I would leave it to him from here on that what did you do next, sir? What steps were taken?
Yeah. Patient was in a new setup, and doctor was also first time doing outside. I am also venturing in recently only. I had come out of the place, so I had asked a chest physician who was there managing intensive respiratory care unit in our institute. He was also practicing in the same area to give a standby and help, because anesthetists are new, though nobody was to be approached. Patient was taken up, and after rapid sequence anesthesia induction, atropine 14 pentacalspoline, my first try direct laryngooscopy, I could not see properly. I attempted again. Well, chords were partially visualized, and then in 1986 only, consumer protection had come. So the tremors comes into hand, and then I said, let us be safe than sorry. IPPV, and then took out the patient By the time the chest physician had joined me, I had helped him in the IRCU when the difficult intubation, they would give a call. So he had some faith. He said, why you can't do it? Think. The thought process that because of the Consumer Protection Act and lot of discussion about medical legal cases started. He said, what about pillow? You want more? Said, why not? Okay. Then we look for a pillow. The pillow that was there, it was soft. So we changed it and put up some bed sheets. Thereafter, they said, what else is happening? I said, my tube is passing behind the larynx and it is slipping away. I said, why don't you give a bend? Then suddenly the stylet clicked in. With the help of stylet and the bed sheets, I negotiated and then case was done. But the bed sheet and stylet remained all throughout my life, and I have managed with them most of the cases up to Malambutti 3. Never gave a trouble. But with most of the new gadgets, I think it's very difficult to have that kind of approach. Now you have to have video laryngoscope and whatnot. But that was a learning phase, and it was really threatening to continue with private practice or not. But pre-operative preparation needed. I had not seen the patient. Patient came up on hospital directly, and that is routine here in this area. They say case is tomorrow, and we see exactly half an hour before. I think that is wrong. A pre-assessment of the airway is needed. That would help whether to select to do it or to not. Anything else? You would like to see the stylet making change in that. The second part was the tube that we used to use, we were trained was red rubber tube. And then the cortex was just coming in. So to save money, we were taking up the cortex, boiling like the red rubber. And in that bargain, it was losing the shape and becoming straight. Maybe that was the reason my tube was not going in, because I just picked up the tube. Well, I will share my stylet video with the share screen. See, this is sometime you see the pillows are very soft, and then they make difference. You take bed sheets, keep, this is my LSCS patient, they always get bed sheets. And here is a video that shows how anterior angulation can help. The stylet passes in, and the tube gets a little bit bent. And I have taken this stylet and used most of the intubation all the time. It has prevented me in getting into trouble. The stylet is short one, not the long one, and I had kept it of the tube size only, so it doesn't come out of the other end. The picture is original shape of the tube, and the tube itself goes a little 1.5 inch of elevation comes up. It has worked out very well with when the epiglottis is hanging and covering the cords also. I lifted up with this tip and passed the tube many times. Well, that is what my case is. Anything else you want to ask? You're welcome, sir. Thank you very much for the opportunity.
Yes, sir. I think very rightfully said, there are many people who might debate about using the stylet actually. Some like to use it, some don't like to use it. But yes, I also agree that sometimes the acute angulation does help a lot of people. So is there anybody, any other panelist who would want to add something to it?
Yeah.
Yes,
Doctor,
yes,
yeah. Actually, no. See, what I feel is having a firm sheets is very important. I always keep 3 sheets for all my patients routinely. And nowadays, I moved away from stylets. I'm using only Bougie. So Bougies are actually longer ones, and then the tip is sort of bit angulated. So any slight anterior larynx, what we can do is sort of keep the bougie, and over that you can pass an electric tube. That saves us a lot of problem and solves a lot of situations also. So I think that's what we always carry. Each theater is provided with the bougie, and that's what nowadays we use. We moved away from slits now, because some of the slits it's not proper. It's not proper. Some of them improvised ones, like the wire ones, can cause trauma. So bougies are quite good, and then probably that should be part of yeah, we should have that always.
Sir is showing the bougie also.
Yeah, exactly. The same one.
Yeah, that's the bougie.
Yeah, so
Angulation.
this is, you can actually see that's the corded tip now.
Yeah.
Okay, that's called the corded tip. So it's angulated, and also you can actually see there's the holes in that. These are actually ventilating bougies.
All right.
So you can, yeah. I have actually.
Are these the proba ones?
Yeah.
Sir, are these the proba ones?
This is a pediatric. This is a pediatric bougie. Okay, this is more of like for pediatric one. This is thin, but this also actually had a corded bougie. Sorry, corded tape. But this is not a ventilating one. Okay, this is a ventilating one. You can actually attach a just like an endotracheal tube connector, and I will actually show in a minute. I'm sure I've got an airway box. Actually, some of these things I might actually have it, I may not have it. They all go missing from time to time. Yeah, I have. Sorry.
So for the same 7 mm connector.
Yeah. So this is actually our intubating catheter, the entry catheter. So you just click it, okay, and then it comes out. So you can put a tube back, but also if you want to ventilate, you can connect a normal, your circuit to it. So these are actually very, very useful. I think everybody should actually have an access to a bougie. The problem with stillets are that they are made of metal. Well, Dr. Anna has actually have this, says a small size, but in most cases it's actually longer. And there are actually chances where the trachea has been torn. The posterior wall of trachea has been torn if it is not properly angled, or it goes posterior, because there is no soft. So we actually have bougies which actually has got a soft tip. So the best thing is, if you're using a wire stylet, you thread a a feeding tube over it, and just leave the first few centimeters out, so that is soft tip. So you can create a safer kind of the stillets with that.
My bag, I had kept this assembly.
Yeah.
Here my gills, and my gills is all entangled in this, and this is small stillet.
Yeah.
So this helped all the way, and it doesn't produce for an adult. For a smaller kids up to 7 and 8, maybe sometime only needed. So I would just bend it.
Yeah. So what I would say is, instead of that, that's one thing. I would actually thread a feeding tube. Thing.
Stopper.
Yeah. So that will make it safer. One thing. Second thing is, before that, you can actually have the rubber cork of a bottle, where you can actually just measure the thing and make sure that it doesn't. So 2 safety features can be added to this stillet.
That is great. I also want to ask, bougies are very flexible. They are very malleable. So is there a way of also preserving them, storing them? There are lots of people who put it in the refrigerator. Lots of bougies are very soft, So anybody would want to take that question.
No, bougies are never. Sorry, are you talking about the bougies?
Yes, sir. Many times when the bougies which have been bought, if they are not preserved well, they actually completely lose their strength, and they completely become it's very difficult to intubate using them.
I don't know. We don't do that.
Meenal, shall I?
Yes, sir. Yes, ma'am. Please.
Actually, I want to show what the point you said, that it can happen, because some bougies are very wobbly, sort of.
I can't see you, ma'am.
I don't know.
Yeah.
Some bougies are very wobbly,
yes.
So many times it is difficult to thread, to put in a bougie and thread the tube. So I personally found Vivek Gupta sir's, our own Vivek Gupta sir's, this thing. It's very useful. This is the particular one. Dr. Vivek Gupta, it's his own creation, and that is stiff also, and at the same time less traumatic. Many people have used it personally and they have given a very good feedback. Shiv sir must be actually can tell more about it. But this particular this is very, very good.
I've used it, ma'am, so I know. Yes.
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 And I just kept it so that people
Very
can
nice.
see.
And Rakhavendra sir, you had something to add to it.
Yeah. Actually, see, the Bougies which we have come at the stylet. So once you introduce it into the trachea, see, the only tip only is bent. It is supported by a stylet, and once it goes into trachea, you can remove stylet, then it becomes soft. So it doesn't wobble at all. So I think probably to have that kind of
Bougie with a stylet. Right.
stylet.
Yes, Dr. Chetna, you have been raising your hand. Please go ahead and make your point, Dr. Chetna.
Yeah, I also make it a point that because initially sometimes I have faced unanticipated airway problems, intubating problems. So now I have made it a point that I will introduce a stylet beforehand itself in the endotracheal tube which I am using. The staff also know about it, so they take care that the stylet tip doesn't go beyond the Murphy eye, and if it goes, they bend it. They are all well trained for this. They always provide me with the endotracheal tube with the stylet inside, and I use the Trutti blade for these cases. So this is a fixed routine now that I'll be using a stylet endotracheal tube and Trutti blade for intubation. Bougie and the Megal's forceps stand by always in case of a difficult airway, and I have had to use the Bougie in an elderly patient and some other difficult cases. So I reloaded the endotracheal tube over it.
Yeah,
So
right,
these
right.
always should be on that,
Right. Thank
ready
you.
by your hand.
Right. So, we, after the discussion with all of us, I think the common ground which we all have reached is this, that there are certain airway hacks which we all need to have. The difficult airway algorithm, unanticipated difficult airway algorithm spoke to us about that only. You need to have an LMA, you need to have a Bougie, you need to have certain other things, you need to have certain skills. And those skills will not just come. We have to learn, practice, attend workshops, keep palpating structures. So I would ask Dr. Raghavendra now. This is a very interesting case actually which happened. So the patient was intubated, maybe a difficult intubation. Uh, yeah, it was a difficult intubation, yes. Maybe anticipated difficult or unanticipated difficult, but it was a difficult intubation. Now the patient was intubated. Post that, he faced a few problems in ventilating the patient. So, sir, if you can just take us through the case, what exactly happened?
Oh, okay. This was done a long time ago, maybe 20 years back. Actually, the case done by one of my senior colleagues, and she had some problem in intubating this patient. He was an adult patient, maybe about some 35 or so, male patient, undergoing an ENT procedure. He had some loose upper teeth, and during the laryngoscopy, the teeth got a bit loosened up and they started bleeding. Okay. So I think, and then she had paralyzed the patient with a long-acting relaxant. Now, what happened is initially the mass ventilation was not problematic, but later it became a bit tough. And then finally, I think she could expose her cords and see only part of it, and with some stylet knowledge, she could intubate the patient. Now, after intubation, we expect the patient, maybe everything's trouble should be over, but nothing, the trouble was actually bleeding at that time. The bag was very tight. It was almost as if you are ventilating against a totally obstructed airway or tube, a king tube like that. So it was a panic situation, and then saturation was dropping very fast. And that's the time when they started, they started calling for help and all. So I was the next OT. And when I went there, see, the patient was blue. The anesthetist was also in distress, and then it was not possible. Just took laryngoscope. The tube was truly in the across the larynx, but bag was very, very tight. Just couldn't ventilate at all. So only way he could ventilate is open all the pop-off valves. Then everything was going out now. So next thing is just to sort of try to pass suction catheter. It's sort of not going freely inside. It is going for some distance, getting stuck and all. So possibility of either a balloon, misplaced cuff or some other kink in the tube beyond the vocal cord. All this came to mind. Then other thing I did was probably, we thought about suction because there was a lot of blood in the mouth also. So, what prompted me, I think a few seconds, no matter in such situations and all. And then I just took a suction tube. Okay, suction tube only I just took, not suction catheter. Remove the connector from the endotracheal tube, attach suction tube to the endotracheal tube, and then I could feel something getting inside, and then I removed the endotracheal tube. Okay, and a long, what do you call, clot, which was totally occluding the trachea, came out. Okay, so that was something, and after that, mass ventilation was quite easy, and then intubation was not that difficult. It was okay. Again, we had to put in a stylet and Bougie, but then it was all quite okay after that. So, faced with the problem of an totally obstructed airway, something like a central foreign body, a foreign body in the trachea, two things they can do. One is they can push it down or take it out. Okay, so taking it out was actually somehow was possible, but I have come across another case where a child, where there was a central where a foreign body in the bronchus, during when we were taking it out, it just got stuck, it just got dropped in the trachea. So in that case, what we did was we sort of pushed it into one bronchus again and then attempted, and then we were able to save the baby. I think I put it in one of the posts also. So somehow, I think these sort of things are desperate situation because we got very little time left to save such patients now. And you can imagine the scenario, because now I think thinking back so many years, I can still now breathe a sigh of relief now. But that time it was all very, very dramatic moments that time.
Yes, sir, absolutely. So, I would like to just share the screen here. And yes, so you see, that is why positioning is so important. The sniffing dog position is where, that we're talking about the pillows being kept, and we're talking about the Oxford. Somebody's also spoken about the Oxford pillow, which they are using in pregnant patients, etc. Sniffing dog position and the entire axis at which, you are able to intubate becomes so very important, right? And calling for help is definitely not a sign of weakness. Indeed, it is a sign of strength. So please reach out to your colleagues. If you're not able to, please don't take it on your ego. Lessen it. Just go ahead with it. Things will be better. Ultimately, we are just going to save the patient. And as for, if you are not able to intubate, give somebody else a chance. It's not a competition. It's not like you have to do it. Somebody else can, maybe, it is not your day that day. Maybe the technique, sometimes we just get exhausted. And as Dr. Raghavendran said, presence of mind and eternal vigilance. What he did, that he was able to suck out those clots, and he was able to think out of the box, that maybe there are clots present, is very, very important. But that all comes from experience. You have to you have to work adequately in the OT under proper guidance, train under the correct people, and simple hacks can sometimes save your life. So now, thank you so much for all the input. So now I would go on to, this is all about unanticipated difficult cases, which people experience and how they handle them. Now coming to certain anticipated difficult situations. We know about all the airway conduits. Sir has mentioned about difficult airway guidelines, everything. But sometimes even the airway conduits don't help us, and we need to have some other hacks up our sleeve, some other tricks up our sleeve. So this next case is all about that. Dr. Jayal, a young anesthesiologist from the gas group who had also presented his case, and he actually got lauded for it. He handled it very well. I would hand it over to him after a brief introduction. A 54-year-old male was posted for septoplasty. He was operated by the ENT surgeon. Dr. Jayal was not the anesthetist for that case. But after the case got over, maybe about 2-3 hours later, he started bleeding post-surgery. So he got a call for it, and he was supposed to give GA so that the source of bleed could be identified, because everything else was tried, all packs and every other kind of drugs were tried. So I would like to ask Dr. Jayal, how did you manage this case, and can you please take us from here?
Hello everyone, and thank you for having me, and thank you for making me present this case. So as Minal ma'am said, that I got a call from my ENT surgeon, and the patient has to be taken under the GA. So the first thing I did my ENT surgeon has told me that it was a difficult intubation during the septoplasty case, and the previous anesthetist has conducted this into the IGL number 4. And so I immediately called him up, and he told me that it was the chromic Lehan grade 4 view, so she couldn't intubate her. And I asked the patient, asked the surgeon to reserve the and issue 2 BT and FFP and take the consent for the post-op ventilator support.
So I would just want to, Dr. JR, I would just want to stop you here,
Yes.
so that we can just take the discussion forward. Dr. Soma, my question to you is not really regarding this case, but can cases, ENT cases of septoplasty, rhinoplasty, etc., can we use LMAs there? Is it okay to use LMAs?
Yes, I think supraglottic AV devices have been in use for quite a period for use in ENT surgeries. And then there are flexible LMAs with the wire reinforced LMAs that are available that we can use for septoplasties and functional endoscopic sinus surgeries. We do have a Basca mask with specifically made for FIS and septoplasty, where the stem is shorter so that it doesn't interfere with the surgeon's hands while manipulating or while doing surgeries. So it's there are lots of studies in the literature that has proven that flexible LMAs are quite good. The trickling of blood into the trachea is very minimal or negligible when compared to traditional endotracheal intubation. But again, the choice of patient selection is important in using such flexible LMAs or supraglottic devices for septoplasty or any other ENT surgeries. If the surgery is going to be tricky or the longer duration and the septoplasty is going to take for a longer period, or when the curvature of septum is too very erratic, and you anticipate lots of bleeding, and a surgeon is inexperienced, and of course, if the anesthetist is inexperienced, and then we should think twice before using it. But once I have used a couple of times this flexible LMA as well as the Basca mask with fantastic results. The extubation will be very smooth for such patients, and the patients will not cough at all, as the patient will cough while extubating an endotracheal tube. So I think we can. It's quite. I think even the literature and the lots of studies support the use of supraglottic devices for septoplasty. Yeah, thank you.
Right. So I think we have a lot of Indian inventions here. Basca mask, sir, if I'm not mistaken, it's also by an Indian only, Basca mask.
Yeah, Basca mask was, yes, it's an Indian invention, but he's an Australian currently.
Yeah,
he's an Australian citizen. He and his wife both are anesthetists, and they are Australian citizens. They do manufacture Basca mask for different procedures. I think I think everyone would have seen, or some would have used a Basca mask. Yes. It's very easy. It has a sump that collects the secretions, and it doesn't. It prevents aspiration. It's very useful. We have used for quite a number of laparoscopic surgeries, ENT procedures, a large number of general anesthetic procedures. We have used Basca mask. The one beauty about Basca mask is as the airway pressure increases, the seal becomes much better. So it's quite very useful in using Basca mask for some patients.
Correct. So is there, Dr. Raghavendra, would you want to add something, or Dr. Shreff, would you want to add something to this?
Say again, I couldn't get it. Huh?
Would you want to add something, sir, to this?
About LMAs?
Yes, sir.
Yeah, LMAs, yeah, you can do, as Dr. Soma said, you can do. It's our comfort level. Many anesthetists don't want to come away from their, the usual traditional endotracheal tubes. But in certain instances, for example, like singers, or where there was something like we're getting to problems and use LMA as a rescue device, then probably definitely can use these devices. And I gave a presentation some time ago about the advantages of using a flexible LMA for tonsil operations. It's routinely used in many European hospitals, and they are quite happy with that. And I have used on few occasions, and I thought someone suggested it was quite helpful. But always, you have to have a surgeon who should also like it, because he should not complain about the presence of a cuff in the oral cavity. And even though they operate a little bit above that cuffs and all, And then you have to have a meticulous hemostasis and all, because sometimes some secretions and blood which can trickle down can cause a reaction. And then always there are ways of doing it, and some familiarity is needed when you're using a flexible LMA for ENT operations, definitely.
All right, sir. Thank you so much. So can we go ahead with Dr. JR? Yes, we can go ahead with you.
Yeah, sure. So we reached to the hospital along with my colleague, Dr. Gujan Gandhi. And on a quick history and examination, we find out that the patient didn't have any comorbidities. The respiratory system and cardiovascular system was checked, and there was no trials or rhonchi were present. Now the patient was bleeding profusely, and when he asked his name or something, he made a gargling sound. So there was very much amount of blood was present into his trachea. So for us, we directly explained to our surgeon and the relatives that we'll go forward with the awake intubation, but fiber optic was not available with us. Plan B was to go for retrograde intubation. Plan C was to tracheostomy, but relatives were refused to do that. And plan D was to give a sedation and airway blocks. But as the bleeding was so profuse, we have to do for the intubation, and we uh, continue with the awake intubation. So just 1 milligram midas glycopyrrolate 0.2 milligram and fentanyl 100 microgram was given to calm his nerves. Airway block was given, and we did a gentle laryngoscopy to see what kind of thing we are dealing with, and there was continuous trickling of the blood. So my friend tried for the 2 attempts, but he couldn't negotiate the endotracheal tube because it's the same thing that it was chromoglyan 4. I couldn't see the visualize. So on the third, I tried for the third attempt, and just immediately I said the patient to say just word say ah. So immediately I could see the cords, and I inserted the bougie and just rerolled the tube over it. Since there was no ATCO2, so we just check for the misting that whether we are into the endotracheal tube not. And after that, we connected the circuit, started the oxygen, and the bag was moving, and the patient was comfortable as I posted the video. And then we induced the patient with the propofol 100 milligram, and simultaneously infected the cuff and other muscle relaxants and oxygen, and the patient was maintained on oxygen, nitrous, and isoflurane. We put the throat pack. Now the paracetamol analgesic was given in form of 1 gram IV paracetamol. Dexamethasone 8 milligram IV was given. Now, since the bleeding was so profuse and already the surgeon was trying so hard, but he couldn't control it, I suggested to do with the posterior packing through the Foley's catheter. We inserted the cuff and put the 40 ml volume, but still we couldn't control the bleeding. The senior ENT surgeon's help was also sought, but it was all in vain. We did the cautery, we used the Foley's catheter, we used the hemlock and everything, but we couldn't stop the bleeding. So ultimately, the decision was taken that we'll do the posterior pharynx nasal packing, palatal packing. And till then, the blood loss was very much high. It was 1.4 liter. We infused 1 PCV and 1 liter RN, 1 liter NS was given. The urine output was frank, and it was 600 ml, so it was very fine. Now the patient was shifted to the ICU. We started the patient on the midazolam fentanyl infusion to continue for the post-op ventilatory support. And we also started the levotalol infusion, which was continue for the 24 hours so that his blood pressure will not go up, and we deal with the bleeding more. And we again give the 2 PCV and 4 FFP. After 24 hours, repeat hemoglobin was done, which was 9 milligram per deciliter. Previously, it was 13 milligram. Coagulation profiles were within normal limit. Every day, the nasal packing was were removed and see for the blood, but there was decreasing trend was seen after 3 days. And on the fifth day, there was some amount of soakage was there. So decision was taken to take the patient on the 6th day, and we took the patient into the operation theater, and all the packs were removed. The bleeding has completely stopped. But for a safer side, as it was a difficult intubation, we continued we did not extubated the patient immediately. We kept the tube in situ for 6 hours, and after that we extubated the patient. Now the patient is extremely fine.
Right, that is excellent. I think you managed it very well. I think you were
Thank you.
also a lot of people actually, commended you on your work when you did post this case. And
Yes, ma'am.
so that is why I wanted to say that it's not just the airway conduits. You have to have some other, hacks also up your sleeve, like these airway blocks. And you
Yes,
also tried to tell the surgeon to induce the tamponade effect with the help of Foley's. So a lot of,
yes, ma'am.
things which we learn while we are working hands-on, not only freelancing, any other place. So
Yes,
here I would like to ask Dr. Shiv actually, so if you could just talk a little bit about the importance of airway blocks, how people only think it's important to use them in fiber optic bronchoscopy, but then otherwise also they are important.
Yeah. Yeah, I think this is actually a very important skill, and they are very simple thing. I think what Jal has done is, I think, just commendable, that he thought about it. And
okay.
yeah, so I think in emergency you can't actually do gargles and stuff like that to anesthetize. But there are a few things you can actually do, which is actually simpler than even doing the blocks. And one of them is actually nebulization of lignocaine. So if you actually have time, obviously in this case, patient was actually bleeding from the nose, not a good idea. So your choice of actually doing a transtracheal injection, which is simple. Okay, it's a very important trick. This also is important for people who actually want to, practice about, front of neck access. So do it, injection. And I think he used only 3 mLs. I would have actually probably used a larger volume. Uh, some of our respiratory physicians, they do their bronchoscopy just with this technique. They go in, put in 2 mLs of 2% lignocaine, all that you need. And then they use the rest of the 8 mLs. So they take the whole 10 mLs. And what will happen is patient will cough and the local anesthetic will move up. So you actually get, the anesthetization of their upper part as well, the vocal cords as well. So they are able to actually do that. And some of them goes down, so you don't actually get coughing when patient is actually, you are putting the tube in, the patients don't cough. The recurrent laryngeal nerve blocks is not necessary in this. Superior laryngeal blocks near the hyoid, you can actually do that, and that gel has actually done in this case. That's amazing. Again, so there are other blocks as well. So anesthetizing the whole airway by using glossopharyngeal nerve blocks and things. I think that's all makes it a little bit more complex. This is more for where you have anticipated difficult airway and you want to actually then anesthetize. But then, like I said, there are simpler ways in those cases. Just use nebulization of lignocaine, easiest thing ever anybody can do. And then you need to
Yes,
also have some lignocaine to spray as you go as well. Okay. But most important thing is that you do not want to exceed the toxic limit of lignocaine. It's only, keep it within the toxic limits. Do not exceed. So calculate that and have that maximum amount of dose along with you. Okay.
Right. So as you said, the cargo technique, spray as you go, and uh, right. So I would like to show something here. Actually, I have a picture from Dr. Case.
Is Jal again? Is it there? It was still there. Yeah. Okay. I thought he's left.
Actually, my presentation is just became very small. I don't know how to make it big.
um, are you on the? Is it a video or is it a PowerPoint?
No, sir, the whole Zoom thing went really small actually. So I was just thinking what happened really. Yeah.
Yeah, you're back. Yeah.
Yeah. So I will just share. He showed me. He sent me a picture actually. Yeah. So this is the picture. This is the amount of blood which actually got collected during that time.
Yeah. It was yeah.
Yes. And these were the rock solid hemodynamics of the patient. I was not able to attach the he has sent me a little 5-second video also, which is not playing right now. But the tube was inside, and he was talking to the patient, and the patient was actually vocalizing with him, right, Dr. Jaya? I mean, he was at least moving. Would you want to say
Yes,
something
sir.
about it? Yeah.
You need to stop sharing the screen first.
Yes.
Yeah.
Yes, Dr. Jayal, would you want to say something about the rock solid hemodynamics which you got with this?
The hemodynamics remained stable throughout the surgery. We gave some of the hypotension with the uh, volatile anesthetic with the isoflurane only, and our main aim was to maintain the hemodynamically stable and maintain the urine output. So we did that, and we the po- it was actually the post of ventilatory. Many have comment about the why it would the patient was not extubated and you didn't go for the tracheostomy directly. But there are some things like that. The patient refusal was the main concern, and as per se, the surgeon was not ready, willing for the tracheostomy, and went ahead with the plan, and it just executed well, and as per the everything goes well because the patient had properly survived, and so we
Good.
were happy.
That's really nice. So you mentioned about 3 plans. You started from fiber optics, and then you
Yes,
said
ma'am.
plan B was retrograde intubation,
Retrograde intubation.
and
Yes, ma'am.
third plan was this, this particular,
This for a particular tracheostomy.
yeah,
I have
tracheostomy.
done, ma'am. I usually whenever I go to the bronchoscopy call, I usually give airway blocks. So I was very versed with the airway block,
Worked with it.
and yes, yes. And I have given, I taken a retrograde intubation. I have done 4 to 5 in ICU, and even I have done one retrograde intubation with the septoplasty with this surgeon only, and I have posted that also on the Facebook. So I was very versed with the retrograde intubation also. So, but I guess we were not ready to pull that off in this patient for that part.
Right, I got it. So basically, yes, ma'am, just a minute. So basically, I would
Just
like to say this that there are a lot of hacks which we need to keep learning, and
Yes, yes,
not necessarily we'll keep using it all the time. But then those small things of palpating the surface landmarks. You should know where the
yes,
cricothyroid membrane is. You should know where you're supposed to
yes,
give the block. That
yes,
has to
yes.
be regularly practiced. At least keep practicing.
Mhm.
Don't forget what you learn, because we go for
Yes,
various of these airway seminars and then we never ever touch the patient. We wait.
exactly.
So the final point, even what Sir said about scalpel cricothyroidotomy, you're supposed to actually know where the cricothyroid membrane lies.
Yeah,
If you are not able to palpate and know which is the cricoid, which is the thyroid, how will we,
exactly.
proceed further? So
Yeah,
please take
exactly,
help from your
exactly.
seniors. Like, this is what. Yes, ma'am. Please, Suchitra, ma'am. You wanted to say something.
uh, yeah, I just wanted to ask Jayan,
Yes,
the
ma'am.
patient refused tracheostomy, but
Yes, ma'am.
had you taken tracheostomy consent separate?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am.
Because
The
it
patient.
is very
Yeah, yeah.
important. It is
Yes,
very
ma'am.
important to tell the patients that we will be avoiding it total. But
Yeah,
if
yeah.
at all in emergency, if it comes
Yes,
to the
yes.
life of the patient, then we have
Yeah,
to go
exactly,
for it.
exactly. We have to go
So
for.
that consent has
We
to
have,
be taken
yeah.
for the
I
medical.
have
Yeah,
taken
only
a
that I
very
wanted to ask.
yes, yes, ma'am.
Great, great. All right. So
And
my
for
next,
this,
yes,
I want to really add this. For this patient, the superior laryngeal nerve block was not easy because I could not. I have tried 1 or 2 times,
feel for the
but
corner.
because the cornu was not hit, so that's why I went ahead with the somewhat larger volume. Otherwise, I give the superior laryngeal 3 ml on each side. But it was said on the Nysura that if you don't palpate the cornu and if you don't feel through the needle, you just ride along with whenever you remove the needle, you just press the for the local volume. It will also give the block. So that's why I give this 5 ml on each side.
Okay, thank you so much. So now I would like to talk about the second. Oh yeah, yes, Dr. Soma, you have something to say.
Yeah. So it's just offbeat, but still, yeah.
Sure.
I always make a point. We are almost for 60-70% of the times we give general anesthesia to patients. So once a patient is intubated and surgery is going on, I always make a point to tell my trainees to palpate for the front of neck structures and find out what is what. And also I'll change the neck to one side to feel for the interscalene groove, to look for the external jugular vein. So you can gather so many points, and I'll try to ask them to put a pulse oximeter probe and the ear lobe and how the waveform is appearing and how we can adjust the positioning. So when we have anesthetized and once the induction and the surgery has started, I think we can make it as a routine point to palpate the front of neck so that at times of emergency, it just our mirror neurons come into play and we can go ahead with the procedure.
Right,
Yeah,
so that
Shiv sir wants to say
yes,
something.
Shiv sir, you want to say something?
So I think there was an article in BJA where they have, this is from UK, they have actually, they were talking about, certain cases where you have sort of, it's not exactly anticipated difficult intubation, okay, but it might be difficult type. And they were actually advocating that you put in a cricothyroidotomy catheter in. So you actually do it, do the intubation, and their logic was that in case they actually fail to intubate, they already have an access. So all they need to do is put a guide wire in, okay, and they can do either percutaneous tracheostomy or you actually just ventilate through that catheter. Yeah. So I think, but obviously there is always a patient consent issues in these. You have to tell them that they are going to puncture the anterior part of the neck, and that it is only for their safety. Once you tell them that it's for their safety, most patients will actually agree to it. And about the why not tracheostomy, that's absolutely fine. I actually sent out an article this morning to you guys, and if you look at it, they actually said sending the patient to the ITU with a tube is a very good way of, in case of we have anticipated difficult intubation, then extubation in the ITU is the best thing you can ever do for a patient. Yeah.
Okay.
So you did the right thing. And as for the video, you have already posted some of the videos on the group, so people actually do have access to those videos. Okay, Minal, yeah, continue please.
Yes. So I would like to ask Dr. Raghavendra now about retrograde intubation. So could you please shed some light? This is again a very important life hack which we as anesthesiologists must have. Dr. Raghavendra. So unmute yourself, please.
Yeah. Say again. What is the question?
Retrograde intubation.
Okay. Yeah. Actually, I want to talk about that option also. See, what Dr. Jayal has done is actually a wonderful thing. Use all his skills and then and put in a Bougie intubation, awake state with some sedation, of course, and a very safe technique. In fact, many times we have to think about those techniques as well. Kindness must give way to safety in such situations. Definitely agree with him. Whatever is done is wonderful. But definitely the retrograde intubation is an option in this patient. And it is actually, it doesn't require much of skill. And once you're done, if you want to two times, it is quite possible. And his airway is actually not, his mouth is okay. There's nothing in the larynx to prevent the passage of guide wire through the past retrograde manner. So that's also a good option. And airway blocks are quite sufficient for this also. So I think that would have been a good option. Now, one thing which I wanted to ask Dr. Jayal Bhagat is, see, you decide to keep the patient with the endotracheal tube and ventilator. Okay.
Yes, sir.
Did you ever consider the idea of putting something like a tube exchanger instead of a tube? And was it? Of course, it requires some sort of tolerance from the patient. Maybe for a short few hours it could be okay, but then we were considering to put it for a few days now. So in that case, probably didn't have much of an option. Okay.
Okay.
But I feel that, but in case you had problem in passing Bougie through the from above, retrograde intubation would have been an excellent option, alternative. Actually.
Okay. Yes,
Okay.
surely,
Right,
sir,
sir.
it would be.
Yes, Jayal, you want to say something?
Yeah, surely, as Raghavendra sir has told, that the retrograde would have been a better option. Yeah, I completely agree with that. And the second thing, that tube exchanger was the problem was that, sir, the patient was constantly trickling the blood through 3 to 4 days, and there was so much the palatal packing, and it was done. The palatal the procedure was very lengthy, and they put the two RT through the each nostrils and taken out from the mouth. It was tied with the gauze and then put into the palatal thing.
So a lot of paraphernalia was there. Your entire mouth was covered, basically.
Yeah,
Very
exactly,
difficult
exactly,
to.
exactly. The
That's
whole
okay. You
mouth
did
was.
well. Right.
Yeah.
Thank you so much. So we can go ahead with the next uh, uh, case, actually. Yes. So this was Dr. Jal's case. Yeah. Right. So this is what is retrograde intubation, which Dr. Raghavendran was speaking about. All right, and all the steps are given very well. You go to the cricothyroid membrane, and then you go ask to take you can take a 2P needle is used, you can take a dual catheter. So it's all. So you have some basic takeaways from this case, which are proper history taking becomes very, very important, because he knew it was a case of difficult intubation. He could understand. Again, call for help. Multiple plans were ready, and managing patient as a whole. Like he immediately ordered for blood, FFPs, PCVs, etc. As the importance cannot be told again and again about anatomical landmarks in doing certain procedures, and also no anesthesia is minor anesthesia. That is very, very important. Now with these takeaways, we go ahead with another case of ours. When we intubate the patient, or when we give an anesthesia, after that normally we feel that we are supposed to watch vitals, but then that's not it. We're supposed to watch everything from airway pressures to capnographs, seismographs, even what the surgeon is doing, what is the color of the blood, etc. And many a times, our patients are completely covered with sheets; they are under drapes, and we might miss certain signs. So this is a case, a very interesting case. But before that, I would like to ask Dr. Soma, so what do you think, what airway conduits should be used in obese patients for superficial surgeries? We all know that we're supposed to intubate them for any deeper surgeries, but maybe a lumpectomy or say an MRM or something like that. What airway conduits should be used?
I don't consider superficial surgery, deep surgery, or anything different. Anesthesia is anesthesia, as simple as it is. It is not like we have surgery can be minor, sutures, lacerations, simple lacerations, sutures has been done. It could be a minor surgery, or cholecystectomy could be a major surgery. But for anesthesia purpose, it is always major. It's even if it's a local case, or we are as a standby anesthetist, or we are going to provide sedation for that patient, I would always like to prepare my airway cart having a plan A to D in an order. At least certain things will be ready. So working in an institution, we do have a difficult airway cart ready for everything. For obese patients specifically, I would like to have a second generation supraglottic device with an esophageal vent for gastric drainage. That would be an important thing because when your ventilation is going to be difficult, we can insert an second generation supraglottic device, put in a Riles tube to deflate the stomach, and ventilation becomes easier. This can be used as a definitive airway for surgery, with proceeding with surgery, depending upon the surgery and depending upon the duration of procedure. And it can be used as a conduit for intubation also when we are stuck up in an emergency procedure. And of course, since if a second generation, a ProSeal or something I'm going to have, I would like to keep an airway exchange catheter, as well as, if available, an entry catheter, so that we do have an entry catheter, so we can use it as a conduit to put an intubation, to intubate through it especially in obese patients. Though not all obese patients are going to be difficult airway, but difficult airway is much more common in obese patients. So I think with pertaining to airway, I would like to keep these two things. And with a video laryngoscope, if available, that would be a great option to add on because it's easy to intubate such patients. So, and one important thing would be our nasopharyngeal airway that will aid me in mask ventilating very easily. Putting a nasal airway and ventilating through that would be a better alternative rather than holding a mask with a heavy jaw on an obese patient. It will be very difficult to ventilate. I think this answers your question, Dr. Meenal.
Yes, yes, sir. Basically, my purpose of putting this question across was that there are many of us who feel that if there's an obese patient, we think it's a difficult airway, which is not the case, which you said very rightly. Not all obese patients have difficult airways. We have to be ready for it. And but then the second generation devices, maybe the Prestige or the, the Supreme LMAs, Prestige LMAs, these can be used, of course, in certain procedures. Right, sir. So I would go ahead with the person who actually did this case, and I will just tell you about his case. So, so this was a 35-year-old female, morbidly obese. She was taken up for laparoscopic sleeve gastrectomy. Uh, the only positive history which was given was that of allergy potential to penicillin. Preoperatively, the chest was clear. The patient was given the normal doses of drugs, intubated. The tube was fixed at 20 centimeters at the lip. Plethysmograph, normal capnograph, stable vitals, stable ventilatory parameters. So Dr. Anwar, who was actually responsible for doing this case, who helped his colleagues together, what really happened next? What can you just take us through it? You can unmute yourself, Dr. Anwar.
Hello everyone, thank you for allowing me to present this case. Actually, very interesting case and a lot of points to be learned from this case. Actually, so when this case was induced and when there was insufflation of abdomen, suddenly the anesthesiologist as the surgeon both noticed there is some dip in oxygen saturation, and there was head up also, and there was increase in airway pressures also. This happened after 10 minutes after insufflation of abdomen. In this period, call for help was sent. The anesthesiologist, he's a senior anesthesiologist, but even then he did not shy away from calling for help, and he called me for help as we are doing regularly the lap sleeve. Me and he are one of the team members for these lap sleeve surgeries. So he called me, and then we checked everything. We started looking for the causes of intra-op erase in airway pressures, as well as difficulty in ventilating the patient, the tidal volume, the set tidal volume. The patient was on volume control ventilation, but we were not able to deliver the set tidal volume. And then the ETCO to trace was also not proper. It was as it suggested, like bronchospasmic ETCO to trace. Then what we did was we immediately asked the surgeon to stop the surgery and reverse the position. Then we did suction through the AT tubes, thinking that there may be some obstruction to the AT tube, but there came out nothing. Then we again we went ahead with giving some nebulization puffs. Ventolin puffs were given, and fluticasone puffs were given. But still, the airway pressures after these maneuvers were not improving, and the ETCO to trace showed still obstruction. So we called our senior-most our HOD. He came, and then he asked us to arrange for a quick bronchoscopy because he suspected maybe there is some aspiration. He asked that whether there was any aspiration during the intubation. The attending anesthesiologist, the initial anesthesiologist, said that no, there was no aspiration during the intubation. So he did a quick flexible bronchoscopy. There was nothing seen in the bronchoscopy. Then he removed the drapes, and then he found out that the patient was red. He asked us what was given, and the attending anesthesiologist said that I started vancomycin during the induction. And this whole scenario happened within 15 to 20 minutes of the start of surgery, that is induction. So ultimately we thought that it is because of vancomycin, so we thought that this is anaphylaxis to vancomycin, though there was minor changes in hemodynamic, like vital signs. Heart rate was minorly raised, not alarmingly raised, low normal blood pressure, but only the sign was bronchospasm and red patient. There were no wheals. So suddenly then we started hydrocortisone 200 milligrams was given, magnesium was given to relieve. Magnesium was given 50 milligrams per kilo was given, started over 20 minutes. And this helped in relieving the bronchospasm, and the rest of the surgery went on well without any problems.
Okay, great. So basically, it was anaphylaxis, which actually caused the entire thing. So anaphylaxis was the main, and because the patient was under the drape, it was difficult for, and again a call for help helped, and again lateral thinking helped, right? So here there is a question from the audience which has come before we proceed. Yes, sir. This question is to you only, Shiv, sir. I have a question. Yes, sir. Please make your comments on the case, Shiv.
So I think there was a history of anaphylaxis here. Sorry, the history of to penicillin, and vancomycin is a known alternative to patients who are allergic to penicillin. And I think this is like an anaphylactoid reaction, which is actually common it's called red man syndrome. So if you actually give vancomycin too quickly, it causes redness. And that is because, and this is actually, here's the histamine release. This is, okay, so it does look like that, might be anaphylaxis to vancomycin, but it is actually a lot of drugs release histamine. And in a patient who is non-COPD, so you actually, did the right things in this case. But you have to remember that antibiotics need to be given slowly, especially in patients who have very reactive airways. It could happen even with a muscle relaxant, which release histamine. Anything which release histamine can give you bronchospastic kind of thing. But what went against the anaphylaxis in your case was that hemodynamically patient was stable throughout. So this is actually an intraoperative bronchospasm because of giving too rapidly. So, yeah.
So my question would be to Dr. Suchitra about the same. I would carry on from what you said, Dr. Shiv. Dr. Suchitra, in freelancing practice, especially, I mean anywhere, but especially I would want to know in freelancing, what do you do about the antibiotics? Do you give them slow? Do you give a test dose? How do you go about it?
Actually, about the testing, the straightforward answer is no, because many a times we see the patient for the first time in the OT itself, though it is a wrong practice. It happens in freelancing, and I don't think that the skin testing is going to avoid hypersensitive reaction in any. It doesn't avoid. So there is no point in doing the skin testing, and if at all, the most important thing is taking a proper history. If at all the patient gives history of any reaction to any antibiotic or any allergy or any asthma, history of asthma or any atopic disease, then the alarm bells should start ringing. And as far as possible, then avoid giving antibiotics which are known to cause hypersensitivity, like beta-lactam antibiotics. So those are very much, they can cause hypersensitivity reaction. So just try to avoid those. As Shiv sir has rightly said, that give any drug in anesthesia, not only antibiotics, not only muscle relaxants, any drug, I tend to use it very slowly. It's my habit because it's sort of a test dose, IV test dose, you can say. It doesn't avoid the hypersensitivity reaction, definitely, but at least we reduce the antigen going into the body, means reduce the antigens entering into the body. And so maybe it is a bit safer. Then I told about the history. History taking is very important because most of the times it is not a proper anaphylaxis. It is just a sort of allergy. It is not. You have to take proper history and avoid the group of antibiotics which can cause this. Yes.
Yes, Dr. Shiv, you
No,
want to
sorry,
say something?
no, it's fine. It's just
Yeah, and
I think,
going much into the anaphylaxis is beyond the scope of today's topic. But
yeah.
just quickly, I want to say a few that in most of there are four considerations. The negative predictive value of skin test is not 100%, because the direct the drug provocative test is more actually important. And there are certain reactions. I won't go into details again. IgE mediated, IgM mediated, IgG mediated. We can talk about it later. So the immediate reactions can be avoided by not giving the skin test, doing the intradermal test. And if at all the skin sensitivity is to be done, it can be reduced over time. And if there is resensitization of the patient, then the skin testing can trigger systemic reaction in approximately 1% of all patients, and 9% of positive skin test patients. So it should be performed in a very by a qualified professional in an area where all the research facilities are available. So there is no just point in telling that do in the ward, do skin sensitivity test in the ward. You are increasing the risk more by telling so. So it's always better to do under your guidance in OT, because OT is well equipped to handle the crisis.
So basically, ma'am, you would want to say that a skin test is not really required, but then giving any drug very slowly over a controlled kind of thing is much better, because we can have reactions even with Rantac, ma'am. Ranitidine also causes reactions.
All the many drugs in anesthesia
so many
can cause.
Yes, sir. Shiv sir, you want to say something?
Yeah, I think that's a very important point, because I think a lot of people in the I think Indian subcontinent, it's so common to actually ask for skin tests being done. And Suchitra has rightly pointed out that skin tests actually on the ward is actually more dangerous. And if you actually look at even the immunologists or the people who are in experts in anaphylaxis, where they do skin tests, they actually have a backup. So that the take-home message is that whatever you do, whether you give a small dose before induction, give rest, this thing, all that nonsense. If it patient has to anaphylaxis, will have anaphylaxis, whatever you do.
Will have.
Okay. It doesn't mean that just because you're given a bucket of dose, you'll going to have anaphylaxis. You can have anaphylaxis even to a micro dose of the culprit, whatever is there. But what is more important is recognizing it and knowing the treatment. The treatment is going to be adrenaline, adrenaline, and adrenaline.
Yes.
Yeah. You use adrenaline and everything disappears with that. Okay.
In fact,
rest of things comes just later. Your bronchospasm things, salbutamol or hydrocortisone, they all are second generation. Your first treatment has to be adrenaline.
And one more thing, that to reduce the severity, if at all you suspect, and if you have time, if suspect a reaction, the allergic reaction to some drug, you can do the patch test, or you can do the intradermal test with a lot of dilution. It should be diluted. So
that's the thing. The dilution used for intradermal test is very, very minute. It is not what you using on the skin test, where people take little part of the thing of usual concentration and try to actually look at the wheel. That can happen with any drug. So it is, first of all, it can give you a false positive reaction to that. The second thing itself is enough to actually initiate anaphylaxis. That small dose. The dilution is not the same as which are used by the allergist. The allergists use very, very dilute solutions. So we cannot actually replicate that in the ward. So it's useless to actually be trying to actually say that you need to do this test. I remember during my time, Dr. Raghavendran will also remember, the gynecologists always used to do this lignocaine skin test.
Yes.
Yeah, they would. It was actually a routine. It was like part of your pre-theater protocol or ritual. It was. There are no meaning at all to it. Okay.
But it is done even now everywhere.
Yeah.
Almost everywhere.
There's no scientific basis. There is no scientific basis to it.
No, but for legal purpose, it is essential. Legality-wise, the drug is tested in the ward.
Dr. Dilip.
Once somebody is written down, then it is approved. and then something happens, you can just put it in a paperwork, something else. But legality-wise, the legal people will be asking, was it done? Because every brochure will mention this test to be done. Without that, please check out the hypersensitivity for the drug. That is a problem, every drug.
Actually, Dr. Dilip, I differ a little in this. See, in the medico-legal cell, anything can be defended and anything can go against you.
Technically, mentioned it there, it removes one
we
part
can't
of the problem.
test each and every
One
drug.
part of the
There
problem.
are so many drugs
Otherwise,
which can cause hypersensitivity.
yeah, every drug has to be tested.
We can just say that the drugs which are highly which can cause hypersensitive reaction, only those drugs are to be tested.
Okay. I think this is not a part of
it. Yes.
Sorry,
guys.
can
go on. Yes.
Yeah, actually, we have a lot of cases to discuss.
Yes.
Actually, there is a question which has also come regarding this. So I would just want any one of you to just give me an answer in 2 lines. Somebody has asked on YouTube that they have trained their technicians to give drugs, when maybe they're not around or they're somewhere else. So is it a correct practice? Actually, I would first want to know. So,
No. That should never be done. The drugs need to be administered by the doctors. Okay. Saying that, yes, technicians can, at times when there is actually emergency situation, that's okay, but don't make it a routine. Don't make it a routine, because ultimately the responsibility is yours. Because if what drug you are actually giving or administering to you, the technician can give a wrong drug. You have actually said, okay, give vacuronium, right? And then he lifts a syringe of tranexamic acid and gives you IV bolus or whatever. Okay, that's where the drug errors actually happen.
There are a lot of neuraxial tranexamic, we have not noted, and there are a lot of case reports. Tranexamic acid in the neuraxial well. So we have to be very careful regarding this. We have to be loading.
Chetna has been raising her hand for a while. Can she actually speak, please?
Yes, regarding this, I have made it a strict routine that I will fill all the syringes, I will give all the drugs. Even though they are used to some other anesthetists who come to the hospital that they ask them to pre-fill the syringes, still I make it a routine that I will fill the drugs myself, I will give them myself. And for most of the important drugs which are transparent, I always label them so that anyone who takes the syringe by chance knows what is filled in that. And usually I keep syringes like atracurium and everything else separately so that it doesn't come into somebody's hand just by that.
Right. So basically, we have a lot of LASA drugs, look-alike, see-alike drugs which are there, and that's we have to be careful as anesthesiologists. So I will take the discussion forward and request Dr. Soma. Anaphylaxis has already been discussed, so he was supposed to make a presentation on this. So, sir, maybe you can quickly run through the protocol of the guidelines for anaphylaxis and also on bronchospasm, mostly in this particular case. Yes.
Yeah. Before that, regarding the technician giving drug, there is one critical incident where the anesthetist has asked the technician to give esmolol, and the technician heard it as Esmeron. Esmeron is the brand name for rocuronium, and the technician has given a rocuronium. And then I think there is a legal issue going on for that case. So I would prefer the technicians not to give any drugs on the. Yeah.
Would you want to share your screen?
Yes. So is my screen visible? So anaphylaxis is an acute, potentially lethal multisystem syndrome, almost always resulting from sudden release of mast cells and basically derived mediators into circulation. It is considered to be more common in adult women than men. The probable hypothesis is because of cross-reactivity of the cosmetic products, that's the tertiary and quaternary ammonium groups in the cosmetic products. The incidence is around 1 in 10,000 to 1 in 20,000 with an 1.5 to 6% mortality because it's being administered through IV most commonly uh, in the OT setup. So we have an allergic and a non-allergic a clinical picture because of involvement of immune system cells. Allergic picture could be because of IgE or IgG mediated, while non-allergic could be because of non-specific activation of mast cells and basophil mediated release. Other pathways can also be affected, such as COX-1 and kinin kallikrein system. A history of asthma, female gender, previous reactions to medications, and patients who are undergoing multiple surgeries and because they are getting exposed to latex and sensitization to different drugs. And patients with mast cell disorders, they're all risk factors for anaphylaxis. I think this has been told in short by Suchitra ma'am. And immediate type skin testing methods are useful in evaluating IgE-mediated reactions. So they can be used as an evaluation in the preoperative period if we suspect or if there is a history of anaphylaxis to some drugs before. The severity of IgE-mediated reactions increase with subsequent administration of the causal agent. And whereas the severity of repeat reactions from other mechanisms, non-IgE mediated, they are usually remain similar. So in this case, if the patient will get a vancomycin, the severity is going to be the same. But if it's going to be an IgE mediated, then the severity will be more. And some IgE mediated reactions are amenable to desensitization techniques. So if retreatment is required, so this can be utilized if at all, if you're going to use such drugs. So more commonly, we come across antibiotics, which is 50% of causes for all anaphylaxis. And blood products, chlorhexidine, which has got around 10% of incidence. In neuromuscular blockers, it's 50 to 70% of all anesthesia-related anaphylaxis because of this. And other agents such as sugammadex, opioids, colloids, latex, albumin, barbiturates, propofol, and all are all implicated to the etiologies of anaphylaxis. There is no trigger; it could be found in specific cases also. Recently, I have come across a patient with meat allergy, and then when gel foam was inserted and as a part of control of bleeding, then the patient had an anaphylaxis sort of reaction. So going back to literature, I found that there is an patients with meat allergy have got some alpha-gal allergy, so they can be prone for allergy to animal products such as gel foam or use of gelafuscin. If we can find out signs and sometimes can be told by patients if they can communicate. So most commonly, 50% of patients will have hypotension and shock, and there will be tachycardia. If the anaphylaxis is very severe, we may have bradycardia. Patient may complain of dyspnea, and there could be wheezing, high peak inspiratory pressures, bronchospasm on clinical examination. There will be an hypoxia or decreased saturation on pulse oximetry with decreased breath sounds bilaterally on auscultation. Angioedema, hives, itching, flushing can also occur. And under anesthesia, it's very difficult to detect diagnose anaphylaxis if there is no proper vigilance. More commonly, anaphylaxis will present with sudden changes in cardiovascular or respiratory parameters. So if we have a proper vigilant anesthetist, it can be detected very early. If few minutes to 20 minutes of IV administration of any drug, it's more likely to be an IgE mediated reaction. And if it occurs within first 30 minutes of anesthesia, it could be due to antibiotics, neuromuscular blocking agents, hypnotic induction agents, and so on. After half an hour into anesthesia, it's more commonly because of latex, blood products, colloids, dyes, etc. And at the time of extubation, if it's reversed with sugammadex, it could be because of that. So immediately we need to call for help and inform the team and the surgeon that an anaphylaxis has been suspected, and we need to look for possible causes, stop the drugs, antibiotics, muscle relaxants, or whatever we are giving, which we think or which we suspect to be the cause of anaphylaxis. Then administer 100% oxygen, secure an airway if not already established, and give adrenaline bolus IV. So for all perioperative settings, we administer IV adrenaline bolus. Maybe in out of OT setup, we may use intramuscular adrenaline. And if there is no detectable blood pressure or the patient has an PEA or arrest or VF VTAC, then we need to initiate your ACLS protocol and act accordingly. And anaphylaxis is one condition. We need to give lots of fluid bolus around 20 to 50 ml of, per kg of fluid bolus so that the hemodynamics can be restored properly. In an ongoing hypotension, can start IV infusions of epinephrine. So I have faced anaphylaxis with which has reverted with around 100 mics of bolus, or some patients needing IV infusions also. And all, as Dr. Shiv pointed out rightly, other therapies like albuterol, steroids, methylprednisolone, H1 and H2 antagonists, vasopressin, norepinephrine, they're all secondary to adrenaline injection. Adrenaline forms the mainstay of treatment for anaphylaxis. And we need to give fluid therapy, fluid administration for refractory hypotension, and we can give up to 50 ml per kg if patients pre-existing cardiorespiratory status are okay. And in refractory shock, we can consider vasopressin and glucagon, and then follow echocardiography should be done to diagnose a transthoracic or transesophageal echo. Even inside OT, if available, can be done to diagnose cause of refractory hypertension. All wheezing is not anaphylaxis, so we need to have differential diagnosis. It could be an acute asthmatic attack, an endotracheal tube malposition, pneumothorax, tension pneumothorax, pericardial tamponade, MI, sepsis, or patients with history of C1 esterase inhibitor deficiency, or patients on ACE treatment who are going in for refractory hypotension following induction, aspiration, pulmonary edema, pulmonary embolism, malignant hypothermia, CHALI, cardiogenic shock, and even bleeding. So we need to keep all these differentials in our minds before injecting the adrenaline, but then anaphylaxis has to be on an high index of suspicion. So we will activate ACLS protocol, as already told, if the patient is going to have asystole, PEA, VFBT, or when there is no detectable BP. And once anaphylaxis is diagnosed, then it's prudent to send serum tryptase levels. At least 1 ml of blood has to be sent within 1 hour, though the serum tryptase levels are elevated up to 3 hours. I know it's very difficult in a freelance setup to send serum tryptase levels and find out. And sending a repeat serum tryptase will be a distant dream in a freelancing setup when the first sample is very difficult to send. And many labs, they do not do. But if we have a facility to do it, we should do it to find out. More than around 70% of cases of anaphylaxis will have elevated serum tryptase levels, though all anaphylaxis may not have elevated serum tryptase levels. So once patient is resuscitated, observe the patient in ICU for 12 to 24 hours and continue steroid for 24 hours. And then later on, we can refer the patient to an allergist. And here comes the important point: when what is it? How to decide whether to proceed with surgery or not? So it has to be taken on an individual basis, depending upon the severity of reaction, cardiopulmonary stability, urgency of procedural interventions. It is safe after grade 1 or grade 2 reaction, but not in grade 3, and definitely not in grade 4 reaction. A grade 1 is where we have a mucocutaneous reactions or rash. Grade 2, the hypertension that is treatable. Grade 3 and grade 4 is a refractory hypertension shock, and grade 4 will be a cardiac arrest situation. So even in emergency situations, the decision to proceed with surgery has not been taken when there has been anaphylaxis. This is quite interesting. I found this interesting, the NAP6 project from UK NHS. So the incidence is around 1 in 10,000. Antibiotics is the most common cause, and actions by anesthetists were prompt, and more than 96% of patients with life-threatening anaphylaxis survived the event because the anesthetists were prompt. Hypotension was the most commonly presenting feature in this NAP6. It occurred in all cases. So we need to have a high index. We need to have anaphylaxis as differentials whenever there is an hypotension. 15% of patients had cardiac arrest and the treatment was prompt, but when the BP was very low, the CPR was often delayed. Elderly patients with cardiac disease and obese patients, they are at risk of cardiac arrest and death, and therefore, if you have a high index of suspicion, you need to treat them aggressively. Teicoplanin is 17-fold more likely to cause anaphylaxis, and 75% of patients needed ICU admissions. And more than 100 days were taken for investigation to an allergy clinic. So I think it is pretty delayed in such a scenario. So the investigations were frequently imperfect, and communication to patients by anesthetists and allergy doctors needs improvement. If this is the scenario in UK, I think we can imagine the scenario in an Indian setup with freelancing. So 1/3 of patients experienced harm in some form, anxiety about future anesthetics was the commonest reported consequence when patients have had anaphylaxis. So I think this is in short about anaphylaxis. So before I have one question to Dr. Mirza. I read somewhere in literature that vancomycin-induced non-IG mediated reaction has occurred to this patient. So Sugammadex allergy or anaphylaxis also takes the same pathway how the vancomycin has taken. So I have no idea. Probably Sugammadex was the better alternative in your setup, or that has been the protocol. So is it possible to avoid Sugammadex when an anaphylaxis has been given, when both Sugammadex as well as vancomycin have take both the non-IG mediated anaphylaxis as the pathway?
Unmute yourself, Dr. Mirza.
Sugammadex was given after the procedure was completed. So once everything was settled, the surgery went on. After 20 minutes after resuscitation, we took the decision to go ahead with the surgery. And Sugammadex was given at the last of the surgery, at the end of the surgery, and the patient was fine, the recovery and all. As you said, non-IG mediated anaphylaxis. I heard about rocuronium also. I read somewhere about rocuronium more with this. Yeah.
No, even I don't have an answer to that question. Probably in yours, if I am in your situation, I would have used Sugammadex.
No,
But no, I just had a curiosity whether
extubation, at the time of extubation.
Yeah, I'll tell rocuronium. One of the first time I used, I had a full-blown anaphylaxis to rocuronium. I still have the records with tryptase level and everything was done. But this patient was actually allergic to most muscle relaxants. Okay, this is a common thing. It's just not, I think, rocuronium. Most of the time you'll find that the patient is actually allergic to other muscle relaxants as well. So yeah, and yes, there is actually a question about whether Sugammadex would be a useful thing because it is going to mop the rocuronium, whether it will be actually useful thing for preventing further reactions. So you will obviously use adrenaline, but at the same time actually use Sugammadex as well, so that rest of thing. But then again, anaphylaxis is basically a cascade. Okay, you need to stop that cascade, and that's why. Yeah.
As the other day, some Dr. Tushar put diclofenac antidote is an adrenaline like that.
Yeah, that's not.
That's
It's just a treatment.
I have one interesting thing. An anaphylaxis, the first representation of an anaphylaxis to succinylcholine is bronchospasm, whereas the first presentation of anaphylaxis to atracurium is hypotension. Contrary to the commonest belief that atracurium will cause. Atracurium causes bronchospasm, though by mast cell release of histamine, but then the anaphylaxis to atracurium presents as hypotension. I think that might be useful for freelancers.
Okay, that is a very useful point. So would you want to go ahead with the bronchospasm presentation also? So that
Oh, yes. Yeah.
We have 3 more cases to discuss. Right?
Yeah, I'll rush through it. It's just a couple of slides. So perioperative bronchospasm can occur as an isolated event or as part of anaphylaxis. So the incidence is very low, 0.2% incidence under general anesthetic. But the effects are going to be severe. If a patient is going to have a severe bronchospasm, they may land up in hypoxia and hypercarbia with increased morbidity and mortality. So the risk factors for perioperative bronchospasm would have a pre-existing history of bronchial asthma and reactive airway disease or COPD. But patients with well-controlled bronchial asthma or COPD, they have incidence equivalent to non-asthmatics or patients who have no COPD. And a history of tobacco smoke exposure, history of atopy, and active upper respiratory tract infections, they're all risk factors for perioperative bronchospasm. We recognize by prolonged expiration, the expiratory wheeze and absent sounds, which is the hallmark of severe spasm or status. In capnograph, we find sharp fin capnograph. And along with, if not timely recognized, the patients may land up in autopep, and hemodynamic disturbances can occur as part of diagnosing. The differentials would be, I think, similar to anaphylaxis. Not all wheezes are bronchospasms. So we need to find out what is the cause for wheeze under general anesthesia. It could be because of partial obstruction of tracheal tube, including an endotracheal tube abetting the carina, or endobronchial intubation. There are certain, I have come across where in a tube kink that happened at the level of pharynx in ENT surgery, when the head was turned to one side, could be was a cause of wheeze. And bronchospasm as such, and pulmonary edema, aspiration of gastric contents, pulmonary embolism, tension pneumothorax, foreign body in tracheobronchial tree, they're all causes of wheeze under general anesthesia. We can have increased peak airway pressures under general anesthesia when the problem with anesthetic equipment where excessive tidal volume has been delivered with high inspiratory flow rates, or when the airway device is of smaller diameter tracheal tube or an endobronchial intubation and the tube is kinked or blocked. And the patient factors could be because of obesity, head low position, pneumoperitoneum, tension pneumothorax, and bronchospasm. So once we come across differentials, we need to find out the cause and treat it. So this is how we manage bronchospasm in the perioperative period. Once bronchospasm is suspected, switch to 100% oxygen. We can ventilate by hand, and we ask the surgeon to stop the surgery and increase the anesthetic depth, and consider allergy anaphylaxis. Rule out as this anaphylaxis is the first step, so that we can stop the administration of suspected drug, and then we can go on to giving adrenaline if it is anaphylaxis, or go on to bronchodilators if it is not so. And when there is difficulty with ventilation, or when the saturation is falling, you call for help and deepen the anesthetic plane. And if it's the ventilation through endotracheal tube is difficult or impossible, check the endotracheal tube position and rule out a blocked tube or a misplaced tube. And if necessary, eliminate the breathing circuit occlusion by using self-inflating bag. I think there is a one case report where the patient was intubated with an endotracheal tube, and the patient could not be ventilated, and found that the connector of the endotracheal tube was totally closed. It's a manufacturing defect. So the anesthetist thought that the patient, the tube is not in the trachea, removed it, and then the anesthetist started ventilating, but then he lost the airway, and then he lost the patient subsequently. In non-intubated patients, we need to exclude laryngospasm and also consider aspiration. And we need to consider drug therapy. We need to consider transfer to HDU or ICU. And we need to, if hemodynamics are unstable or the bronchospasm is severe, and if there is provided, we need to provide ongoing therapy and address the underlying cause by optimizing mechanical ventilation. Since the expiration is limited, we can increase the IE ratio and reconsider allergy anaphylaxis. And if there is no improvement, rule out pulmonary edema, pneumothorax, pulmonary embolism, foreign body, and all, and consider abandoning or aborting the surgical procedure, request and review a chest X-ray, and consider transfer to critical care area for ongoing investigations and therapy. The first line of therapy would be a salbutamol metered-dose inhaler, and we can also use nebulization of salbutamol with 5 milligram and repeated, or an intravenous 250 mic slow IV followed by 5 microgram per minute of salbutamol. And second line therapy could be ipratropium bromide, magnesium sulfate. It's very useful in breaking severe bronchospasm, steroids, and ketamine. Ketamine is a powerful bronchodilator. It's very handy in many cases. And when nothing works, then again, we need to go to the adrenaline that will, and a 5 ml of, I think, I remember Dr. Piyush, where he used to tell 5 ml of adrenaline inserted, put in a nebulizing chamber and nebulizing, and without even any hemodynamic disturbances, the patient's bronchospasm will break beautifully. I think we had a good interaction in their ACE group. And if needed, we can give intravenous adrenaline also. So this picture I wanted to show, if we have an inline MDI adapter, we can use this so that the 100% oxygen is not hampered. But if it is not available, we can put the canister inside a 50 ml syringe and attach at the level where we used to connect the ETCO2 monitor, and then we can give a puff so that this can be delivered into the endotracheal tube. So a patient will be getting 100% oxygen at all points of time. So I think this 50 ml syringe, this picture is, I borrowed this from our anesthetist group put by Raghavendran sir. So this will be very, very handy in managing perioperative bronchospasm. Thank you very much.
That is great, sir. Hello. Yeah. Can you hear me? So that is
Yeah,
great,
yes,
sir.
Meenal.
Yes. Yes. Thank you so much for all these inputs. And let us now go ahead with the case, with the other cases, I think. Yeah. So basically, the takeaways from this case have been many. We have, ventured into anaphylaxis, anaphylactoid reactions, red man syndrome. Even I see the YouTube audience is taking active interest and they are having their own discussion there. So basically, start from the basic. Okay, high index of suspicion is very important. Whenever there is any positive history, please do not ignore it. And it is also very necessary to know when to stop. That slide, the last slide which Sir showed, anaphylaxis, whether to go ahead, grade 1, grade 2, you may go ahead, grade 3, grade 4, you may need to stop. So these things are very important to know. Now, the next case is a case of laryngospasm, basically. Okay? So, this is done. Now, again, Dr. Anwar had performed this case. It was an 85-year-old male for open inguinal hernioplasty, ASA grade 2, NYHA2, smoker. Preoperatively, chest is clear. Dr. Anwar, I'm not too sure whether you intubated the patient or you put an LMA, but I think you intubated the patient. All ventilatory parameters were normal and the surgery was totally uneventful. Would you want to take us what happened beyond that, Doctor?
Okay, madam. Thank you for giving a brief introduction about this case. Actually, this case was done by a very senior anesthesiologist. He's a very safe guy. I know him. He is next to our HOD. So this guy was actually 85 years old. Surgeon wanted intubation. We did endotracheal intubation. Intubation was taken up because ours is a very private hospital, VVIPs. This guy was a VVIP, so the surgeon didn't want the patient to be awake and listen to what is going on and see what is going on. So we had to intubate this guy rather than give a spinal or do a regional anesthesia for any kind of purpose. After intubation, everything was fine. The surgery went on uneventful, and according to the an attending anesthesiologist, he did this case. Intubation was smooth under video laryngoscopy. Usually, this guy uses video laryngoscope, CMAC, directly if there is patient is old as well as when the patient is obese. So he uses CMAC, so single attempt intubation, atraumatic intubation. Case went on fine. Post introp pain medications were given as per the protocol. There was even post-op, post-surgery, this one, a tab block was given by him, and extubation was done. Patient was fine in the theater, shifted to recovery. After shifting to recovery, he was extubated in deep lane actually, thinking that this patient is a chronic smoker, 85-year-old. They didn't want and VIP guy, they didn't want him to struggle during the extubation. So in a little deeper plane, the patient was extubated, shifted to recovery in drowsy state, but responding. He was responding to commands. In recovery, when we were passing by, we could hear that his respirations were like noisy breathing, like inspiratory stridor. And within 2 minutes, it became more noisy, and we had to go there and do jaw thrust and chin lift and jaw thrust, open his airway, put an oral airway. We did that, but still there was tracheal tuck present, and there was some sort of obstruction occurring. His saturations were hovering around 90% and all like that. But then we gave with so we thought that if the patient may be having some residual paralysis. Initially in the OR, he was at the time of extubation, he was given neostigmine atropine. So we thought that maybe there is recurarization. So Sugamadex was given because Rocuronium was given as an muscle relaxant. So we gave Sugamadex 2 milligram per kg. We also thought that maybe because he tab blockers given, so his residual opioid effect may be there. So naloxone was given 400 mics. And to further, stem the recovery, we gave calcium also. Uh, the glucose was checked, it was normal, temperature was normal, and but still there was still laryngospasm occurring. So we thought that okay, and this took around 10 to 15 minutes. The saturation started to going down up to 85, 80. Then we thought of giving a propofol just to make him a little bit deeper and give CPAP. In the meanwhile, I got a machine from shifted from the theater. We have a machine in the theater, spare machine with sevoflurane, and all the preparations were done for immediate intubation. But since we want to take a chance, we took a chance. We didn't want to re-intubate this guy because he's a VIP guy. So we took a chance. In the meanwhile, he developed negative pulmonary pressure edema also, because when we heard his chest constantly, there was crackles were heard. So we gave Lasix and we started through the machine CPAP, and we gave him sevoflurane. So after around 90 minutes, things started to slowly come back, and he improved. We further observed him for 2 to 3 hours. He's fine, and his further stay in the hospital was okay.
Okay, thank you. Thank you for this discussion. I think you managed the case really well. So I would want to ask this one question to Dr. Soma. Dr. Soma, many a time when we begin, initially, when we've given the patient a drug and the patient has just gone deep and the surgery has started, say a DNC, DNE, anything like that, the patient starts hiccup, you know. So firstly, I would want you to talk about those, why are there hiccups basically, and also how to eliminate them. So is giving choline the only way of eliminating them? Is deepening the plane eliminating them? How do we go about it? And is there a mistake on the part of the anesthesiologist actually?
I think I feel it's about the depth of anesthesia. So once we increase the depth of anesthesia, those hiccups will go off. So it's all about maintaining the patient on an adequate plane. So I think we need to have in synchrony with the surgeon observing what he's doing. If the stimulus is going to be so painful, and we need to adjust our inhalation agents or intravenous anesthetic agents accordingly so that the hiccups may not occur. And moreover, we need to have an how the patient is breathing. If there is going to be if the patient is going to be in a deeper plane of anesthesia, there could be an upper airway obstruction happening with a sort of a stridor or a tracheal tug or something. So once we open up the airway, then the patients may regain their normal respiratory breathing pattern. So I think this comes with practice. Most of the cases done under sedation, or if we use iGel or supraglottic device with spontaneous breathing, if they get used to it, I think we can avoid such practice. I can avoid using succinyl choline. And I think there's no harm in using succinyl choline if there is going to hiccups and it's going to affect the surgery or anything. And moreover, if the hiccups it's coming at the end of the surgical procedure, you don't want to give more amount of ketamine or propofol or inhalation agents. You want to finish off the procedure quickly. You can give a small dose of succinyl choline so that the hiccups will disappear, and then you can ventilate for a couple of minutes. And then once the breathing resumes, by the time the surgery has got over, the stimulus is over, and then you can awaken the patient accordingly. So I think I have answered your question.
Yes, sir. I specifically asked this because a lot of times, we are all in a hurry to start the procedure, and even without the patient being in a deep plane of anesthesia, a lot of times, they start cleaning maybe the vagina or something like that, and then the patient suddenly, gets into those hiccups. Which is a very common thing which is seen in at least freelancing. I've seen it many times. I have also done this mistake, and sometimes asking others also. Right. Thank you, sir. So, Dr. Shiv, I would like to ask you, what are your thoughts on the way the case was managed, this particular case, also pulmonary edema? Of course, negative pressure pulmonary edema is a known complication associated with laryngospasm. About 1% of them go into this. But is there a possibility that the patient might also have an underlying cardiac disease which might have been missed earlier? So, please, your thoughts on that.
Yeah. So I think obviously, as the term itself says, it's a negative pressure pulmonary edema. So patient is trying to breathe against a closed glottis, and that's what it causes. I mean, there's so many hypotheses of that there's increased venous return, increase in the your afterload, there is a sympathetic surge. So, and obviously hydrostatic mechanisms come into play. Those besides the point, point here is that the vocal cord is shutting. And this is very common in patients who are in light plane of anesthesia. That's why laryngospasm happens. So when I discuss about safe extubation guidelines, I will likely talk a little bit about it. Then there is other things as well. So this is not only can happen in patients where you are trying to extubate deep and the residual effect of anesthetic persist in the postoperative period. It can also happen in patients who you're trying to actually wake up. So if you have endotracheal tube and patient actually suddenly bites on it when it's trying to, even that can actually cause negative pressure. So you have to be careful in both situations. And now in this case, patient was actually extubated deep, and the patient was probably still had residual effect. The one of the things which people forget, when patient actually is still deep, they're not breathing, there is actually CO2 retention. Okay. And if you actually have this patient, it's better to actually keep the mask on. You extubate them deep, right? I will not actually shift the patient onto the recovery. Okay, I will actually keep the mask on. This is what I do. Sit them up, have a mask on, tight this thing, and apply a bit of PEEP. Let them wake up. Do not transfer the patient when they're still sleepy. So that's where in this case, I think that was done. The patient, they were in a hurry to actually shift the patient. I wouldn't be. Okay, this has been actually asked because I actually do deep extubations in a lot of patients. Even for my IGELs, they come out extubate. I've not had a single case of that because, first of all, I actually switch off the volatile anesthetic at the right time. So there is no persistence. So by the time I'm taking out the supraglottic device, your MAC awake, that is around 0.2 to 0.3 should be there. Okay. And then you need to maintain the airway. The patient cannot actually get washout if he's not breathing properly.
Yes. Open the airway.
Yes, you need to actually have airway which is patent. I think that's all I want to say. There is obviously another drug called magic drug, I call it, called doxapram.
Doxapram, yes.
Okay, if you actually have anything, just give them a stimulate respiration. Patient just washed out very quickly, and then they'll wake up like that. I've shown it so many times. I have patients in the recovery. I said, "Come, I'll show you magic." Okay, without doing anything, give just 20 milligrams of doxapram, and they just huff and puff, wash out the CO2. So CO2 is washed out, as well as the volatile anesthetic washed out, and they wake up like magic.
That is great, sir. Thank you for those insights. Of course, we are coming to the same things again and again. Be careful. When you are extubating the patient, don't be in a hurry. The correct time when the anesthesia drugs should be switched off, your gas inhalation should be switched off, awake mat is necessary, monitoring is necessary. All these things are just not to be said, these are to be practiced. So I would also want to tell my audience that, knowledge is one thing, application of knowledge is the other. So it's very important to keep applying that knowledge. So from here on, I would take this question to Dr. Soma. Would you want to tell a little bit about deep extubation strategies and where all should we basically do?
Deep extubation is when you remove your endotracheal tube when the patient is still under anesthesia and his airway reflexes are not returned. So deep extubation is warranted when it actually decreases cardiovascular stimulation. It reduces the incidence of coughing and straining on the tube. So we usually use it in pediatric anesthesia or in neurosurgeries, head and neck surgeries, and some ENT procedures. The first thing I would like to ask myself is my patient suitable for deep extubation? So if my patient is having history of GERD or a full stomach, then I would think twice before attempting for deep extubation, as the risk of aspiration is very high. And identify, and moreover, if my patient is going to be a difficult airway, again, I'll think twice, because if I'm going to lose airway after extubation, what next? That will be a big question. And also in patients with obesity or patients at risk of aspiration of gastric contents, or in patients having some blood in the pharynx or a lack of upper airway reflexes and so on. So before extubating a patient, we need to clear the airway from secretions. It's important to have a direct laryngoscopic vision and do the suctioning of the oropharynx, especially in patients with sinus surgeries or oral surgeries, and make sure the patient is actually deep. So I'd like to keep a 1 mAc of inhale anesthetics before going to do a laryngoscopy so that response is ameliorated. And then we need to assess the patient's ability to breathe appropriately and spontaneously without the need for a ventilator support. So the patient should have a normal spontaneous pattern of respiration with a normal respiratory rate, and use a pressure support mode with PEEP if needed. And then I would also consider an airway adjuncts before extubation. Like I'll put a nasopharyngeal airway before extubating such patients so that the patient will maintain an upper airway and then the patients will breathe easily. So it's the nasopharyngeal airway is better tolerated than an oral airway, so it's always useful. The important step I would like to do is to pre-oxygenate the patient before deep extubation with FiO2 of 1. That's an important thing because after extubation, if the patient desaturates, if we are going to extubate with a lesser FiO2, it's going to be tricky. And pre-oxygenation is as important as before deep extubation as it is important before your intubation. And after this step, well, I'd like to extubate the patient and deliver a high flow oxygen. There will be a momentary breath holding of around 20-30 seconds. And at that point of time, if I'm going to ventilate the patient, I may push a blood clot or secretions into the larynx, and I can stimulate, I can create a laryngospasm. So I would like to avoid, and I would like to, to avoid this remote risk of laryngospasm. If it's momentary, 10 to 20 seconds of apnea could be tolerated. And I would like to use a triple maneuver, a chin left jaw thrust maneuvers to maintain airway patency if a nasal airway is not inserted, like if a surgery has been done for fist and nose has been packed. And again, I'll reassess for any airway obstruction after extubation, like the presence of a tracheal tug or stridor, or there is a seesaw breathing. And then, of course, we have to be ready for a re-intubation with all our gadgets in place. And if we are going to re-intubate after a deep extubation, then our deep extubation strategy is a failure. So we have to avoid re-intubation at any cost. And as Dr. Shiv told, it's always prudent to shift the patient not just out of OT, right? From the OT table to the trolley, only if patient is able to maintain the airway without airway maneuvers. The patient has to be maintaining an upper airway properly, maintaining saturation and a good adequate respiratory depth and respiratory rate. A couple of exchanging an LME for a tube, such as a Bailey's maneuver or use of dexmedetomidine infusion and a propofol bolus, or if available, a remifentanil infusion. They all can be used as a part of deep extubation strategy, though they form a part of smooth extubation strategy rather than a deep extubation strategy, but still they can be utilized so that we can go ahead with deep extubation. So I think DAS has given algorithm for an extubation guidelines. So the low risk or if the patients are at low risk for category for extubation, then it's prudent to go ahead with a deep extubation. And if the patients are at risk for re-intubation, then I would avoid. I think Dr. Shiv will speak in detail about extubation algorithms.
Yeah. Yes. Thank you, sir.
Thank you.
So
Thank
basically, good suctioning is also very important. Another takeaway. And nasopharyngeal airway, I don't think we can underestimate its importance in any way. It's easy, it's soft, malleable. It's a very, it's not very expensive. I think this is another airway conduit which we should all have with us. At least I carry it in my freelancing kit also. I carry because where we go, we don't normally get these airways. Most of the freelancing places. So, having said this, I would now hand over the discussion to Dr. Raghavendran, who would take us through the laryngospasm protocol and how to actually go ahead once we come to know that the patient has gone into larynx.
Okay. Am I seen now? Hello?
Yes, sir, you're seen. You can just share your screen, sir.
Yeah, I'm sharing now. Is it seen now?
No.
Is it seen?
You're not sharing the screen, Dr. Raghavan.
Oh, 1 second. Hold on. Okay. Is it on?
Not yet.
Okay.
Are you actually on your PowerPoint? Is your PowerPoint open?
Yeah.
You're not sharing the screen.
Yeah, 1 second. I'll come. 1 second. Come.
Well then, Shiv sir, if you would want to take an audience question.
Okay, I think I'll just try 1 second.
Yeah. Till then, Dr. Shiv, if you would want to take an audience question. There are plots to, if you could just explain the stacking of pillows for any of these obese, laparoscopic gastrectomies, etc. So the stacking of pillows, if you could explain that.
Yeah. So basically, it's a ramp position, which I think you showed at first a image where your the ear lobe need to be in the same level as your sternum, and that's only possible to actually have lots of pillows under the shoulder till you actually get this both structure in the same line. So that is what is a ramp position. So you would require pillows under the shoulder as well as under the head. So you need to keep using sheets for it. So Oxford Pillow does that, the ramp position. I mean, I have images of that. I can show it later on, but I have posted it in the group. And same thing has been discussed many times. Yeah, I think Dr. Raghavendran's is there.
Has it come now?
Yeah,
Yes,
it's there now. You can go on to the slideshow. Yeah.
Okay, 1 second. I'll just.
Yes, that is right. The ramp. Actually, sir, I think there are certain institutes which have also made this entire ramp pillow. They have it.
Yes.
They have a ready-made. They don't have to put pillows each time. They have made that, and that is
Yeah.
also very beneficial.
Absolutely.
Has it come now?
Yeah.
Yes, sir. Please.
Okay, now we're just going to talk for a few minutes about laryngospasm, which is quite a dreaded complication, about its recognition and its treatment. Now, as you all know, laryngospasm is sustained closure of the vocal cords, resulting in the partial or complete loss of the patient's airway. So, although described in a conscious state and associated with a silent reflex, it is a problematic reflex which occurs more often under general anesthesia. It's a primitive protective airway reflex that exists to protect against aspiration, but it can occur in the lighter planes of anesthesia. Now, what are signs and symptoms? We can always pick up the inspiratory stridor, which can occur when a child wakes up from anesthesia because a drop of secretions touches the larynx and child instantly makes it going sounds. You can observe increased inspiratory efforts with the tracheal duct, etc. And you can also observe paradoxical chest and abdominal movements. And left untreated, this problem can quickly progress to complete airway obstruction with desaturation, bradycardia, central cyanosis, and further on to pulmonary collapse, and also can also lead to hypoxic ischemic encephalopathy. Before we go any further, let us study the role of intrinsic muscles of larynx in the causation of laryngospasm. We all know that, there is only one muscle named the posterior cricothyroidotomy muscle, which is involved in abduction. As opposed to that, there are three muscles minimum, which are the oblique interarytenoid muscles, the transverse interarytenoid muscle, and also the lateral cricothyroidotomy. They are very powerful muscles. So whenever any reflex is initiated, on the efferent side, the adductors take over, and they are much more powerful than the abductors. So usual reaction which you see is a vocal cord adduction. So what are the triggering factors? It is triggered by a periclotic stimulus mediated via the vagus nerve. The sensory fibers from laryngeal, mechanical, chemical, and thermoreceptors ascend via the vagus nerve via the internal branch of the superior laryngeal nerve. And the highest receptor density exists posteriorly at the true vocal cords, where foreign materials is most likely to spill into the airway. Now, there are anesthesia-related factors. It can cause due to many factors: anesthesia-related, patient-related, and also surgery-related problems. Now, as far as anesthesia-related factors are concerned, it could be due to insufficient depth of anesthesia, and it occurs it may occur during induction or during maintenance, especially with when you're holding a mask or with the LMA. It can also occur at the time of emergence, especially after extubation. It could occur due to airway irritation from volatile agents used in any high concentrations, or because of mucus or blood trickling onto the larynx. Halothane and sevoflurane are the least irritant potentials. It can also occur because of manipulations like laryngoscopy or insertion of suction catheters. And airways, ET tubes, and LMAs also can initiate this laryngospasm, especially if the plane is not right. And certain agents like thiopentone, they lack the suppression of airway reflexes. So after induction, sometimes they can also initiate a laryngospasm. Propofol is unlikely to do such things. And as far as the volatile agents are concerned, desflurane is irritant. And in the order, we have isoflurane, enflurane, halothane, and sevoflurane. Laryngospasm can also occur due to inadequate reversal of muscle relaxants, which occurs quite commonly because adductor muscle, as I said, they are more they have a faster recovery and they act in a stronger manner. Experience of anesthetists who are handling children always matters because inexperienced anesthetists are more likely to cause laryngospasm. And there are other factors like age. So younger children are at greatest risk of developing laryngospasms. And airway hyperactivity also plays a role. In patients who have got asthma, there is 10 times increased risk, and especially if they're in acute phase of asthma. There is a 10-fold rise in incidence of laryngospasm in people who are having upper respiratory tract infections of up to 6 weeks. So it is always advisable to delay elective anesthetic for at least 2 weeks. And LMA insertion carries a lower risk in such patients than the endotracheal tubes. Tobacco smoke, chronic use can also cause risk of laryngospasm. So we had asked the smokers to abstain for at least 2 days prior to the surgical procedure. And there's a 10 times increase in the risk in children who are exposed to passive smoking. The patient risk factors also include obesity with obstructive sleep apnea, gastroesophageal reflux disorders, which could be a primary, can also result in a primary aspiration or related to chronic inflammation of the upper airway. Because the gastric juice keeps on trickling up, especially at night time, and they can cause chronic inflammation of the larynx. There could be some airway anomalies like which predispose laryngospasm, like subglottic stenosis of ASIS, laryngeal papillomatosis, cleft palate, vocal cord paralysis, laryngomalacia, tracheal stenosis, Pierre-Robin syndrome, etc. And others conditions include elongated uvula, history of choking while sleeping, febrile non-hemolytic transfusion reactions, Parkinson's disease, especially who are on withdrawal of treatment, and psychogenic causes. The surgery related factors. There are some particular types of operations where there is laryngospasm is prone to occur, like tonsillectomy and adenoidectomies, and can occur after thyroid surgery due to superior laryngeal nerve or recurrent laryngeal nerve injuries or hypercalcemia secondary to accidental parathyroid gland excision. And sometimes after esophageal surgery due to stimulation of distal afferent esophageal nerves. And we all know the Brewer-Lippard reflex, which occurs following a cervical dilatation in lighter planes of anesthesia, where it leads to laryngospasm in a reflex manner. Appendicectomy, hypospadias repair, skin grafting, they require quite a good depth. And if done in lighter planes, then they can also lead to laryngospasms. Now, how do you prevent them? There are some drugs which probably are helpful in the prevention of laryngospasm. Magnesium is one such one. Given a dose of 15 milligrams per kg, and administered intraoperatively has been shown to reduce the frequency of laryngospasm after awake extubation in a small but well-designed study of pediatric adenotransmitter patients. It is probably due to increased depth and also muscle relaxation it offers. Lidocaine we studied both topically as well as for IV route for prevention of laryngospasms. So for topical lidocaine, you use a dose of 4 milligrams per kg applied to larynx before intubation is done. It often helps in laryngeal operations in the postoperative period. And lidocaine IV before extubation, given a dose of 1.52 mg/kg, it also helps to some extent. We don't know really how much it helps, but there are some studies indicating that they are helpful. Atropine is thought to reduce the risk of laryngospasm by its anti-sialagogue action, reducing the amount of pharyngeal secretions. Its use to prevent laryngospasm is unproven, though. So how do you treat it? So classically, the treatment consists of removing any triggering stimulations. For example, if you're doing any intubation or insertion of suction catheters or airways, lighter planes, just stop doing it. Ensure a clear larynx, checking, and then check for blood or stomach contents in the mouth. So suck it out, clear the airway, and relieve any possible supraglottic component to the airway obstruction. So we do the triple maneuver, chin up, jaw thrust, and extension of the neck, etc. And then application of CPAP with 100% oxygen, and never hesitate to ask for help should the condition the patient deteriorate and saturation is dropping, and then you're not very confident of managing the situation, especially in a child. So during emergency phase, one may be tempted to sort of sit it out, sort of wait and watch policy may be followed. But after observing that the airway is quite clear. However, if it's not really settling down, the only option left is either deepen anesthesia or to paralyze. So inhalational agents are not a good choice for such deepening the plane. So we had to resort to intravenous route. We're using IV propofol given a dose of about 0.5 mg/kg in incremental doses. The cardiovascular adverse events at this dose are relatively minor, although a patient may become apneic. So a patient may have to be supported with mask ventilation after giving a propofol. It can be used alone. This itself will be enough, or it can have to sometimes give hexamethonium and start with lower doses, 0.2 mg/kg. Sometimes it can go up to even a higher dose, up to 1 mg/kg. And whenever we're using, whenever you're in a pediatric theater and giving anesthesia for such children, always useful to have some pre-prepared syringes of propofol as emergency drugs in addition to atropine and hexamethonium. So never hesitate if the laryngospasm is not clearing up in the expected time. And during the emergency phase, patients should be extubated either in a deep plane of anesthesia, about which Dr. Soma already talked about, or if you think that it is safer, always better to extubate patient in a fully awake, but not in between, because this is a dangerous situation. And this holds good for tracheal tubes as well as for supraglottic airway devices. So there are some anecdotal treatment options with limited evidence base. And they include Ross's maneuver, which is a bilateral firm distal pressure on the stylet process behind the posterior ramus and mandible. It is essentially a vigorous jaw thrust with pressure between the posterior ramus and mandible and anterior to the mastoid process. This maneuver is reported to break laryngospasm anecdotally, but has not been subjected to study. And they say a lot of theories have been put forward about this beneficial effect. Superior laryngeal nerve blocks have been described to successfully treat recurrent laryngospasm in a small series of cases, as it breaks the front side of the reflex. Doxapram is a good drug in respiratory stimulant, or nitroglycerin infusions have been reported as case reports to treat laryngospasms. And gentle chest compressions have been reported as a novel treatment of laryngospasm. A non-randomized study, which about 600 children undergoing adenotonsillectomy in each arm, showed an almost doubling in success on treating laryngospasm using this technique over a traditional one of CPAP. What they do is they use both hands or the chest and then keep a nice firm pressures at rhythmic intervals. And you're supposed to increase intrathoracic pressure, which is transmitted to the airway and somehow open the larynx, and the spasm settles down. So this is the Lawrence's maneuver. The firm distal pressure is applied bilaterally, or maybe one side also, between the ramus and mandible, below the condyle and the mastoid process, in upward towards the base of skull and also medially. So you can sort of, it's called as a laryngospasm notch, and then adults, you just keep applying pressure. Probably it also helps to pull the jaw forwards and maintain the airway. But somehow there are reports that it is actually quite helpful. So laryngospasm is as I mentioned, it's a direct complication. It can convert a patient who is in a ASA grade into AS6 category if we don't recognize the complication well in time and act very swiftly. And you don't want a child to go into some pulmonary edema or some sort of ventilator therapy for a few days, and may sometimes even die also. So we have to be careful with this complication and act at the in a correct manner at the very fast. Thank you all.
Thank you so much, Dr. Raghavendran. Thank you for your input. So I think that's about the laryngospasm case. And then we have about half an hour more to complete the rest two cases. So we have to be a little quick because they're also very important. So, like intubation is important, extubation is even more important. As they say that, it is like landing of the plane. That is what happens basically, right? So, but in other planes, etc., you can still put it in autopilot mode. Here, we really can't do that. We have to be present. We have to be eternally vigilant till the patient is shifted to post-anesthesia care unit. But then again, lots of times errors of judgment do happen. So I'll be sharing a case with you about extubation. Like this is something which I caught from the internet. It was really interesting, which says, I was dreaming that I was dancing. When my surgery ended, I was annoyed that they didn't let me finish my dancing. So this is how, the patients, they can sometimes feel, oh my God, really khatam ho gaya? Itna jaldi khatam ho gaya? Pata bhi nahi chala. That can be the kind of anesthesia which you've given. They're pain-free and they are so happy. But some other times it can lead to a lot of complications. So this is our next case. 19-year-old female who was having microagnathia was actually taken up for mandible correction surgery. Interdental wiring was done, was planned for this patient. So nasal intubation with throat packing was done. The surgery was absolutely uneventful. Interdental wiring was done, which lasted for nearly 3 hours. So now, from here on, this case was actually performed by Dr. Suchitra. I would request her to tell us what exactly happened. Yes, Dr. Suchitra.
Yeah. Yeah. Thank you, Meenal. Actually, just I want to tell briefly the background about this case. First, let me tell you, this case happened some 20 years ago, so I may not recollect all the things, and maybe there might be some mistakes while explaining the case. So it was a 19-year female. And actually, she was posted for micrognathia correction. The intubation was not difficult. I did a nasal intubation, obviously, and it was done under vision. And something I don't remember exactly, but some small 6 number tube was put because the patient this was quite petite. That girl was quite petite with around 40, 45 kg weight and just 5 feet height. And the case was done properly. Some 2.5 hours the surgeon took. And that time, some 20 years ago, I had the setup in that particular setup. I had recently come to Pune. I shifted to Pune. So I was not very much used to all this type of cases. When in my previously, I used to practice in Bhusawar. It was a taluka place. And that time, it was actually these type of cases I didn't do much. So it was sort of new. And the Boyle's machine was an old one with conventional Boyle's machine with a closed circuit. I had used closed circuit. I had halothane at my disposal, and all the basic drugs like pentazocine and Midas was there. And I used halothane as an inhalation agent. So after the procedure, the patient was actually, she was young. So she came out of anesthesia, and the surgeon had gone away. The main surgeon who was doing the case, he had actually left the theater, OT theater, and his assistant was there. He was very much junior, and he was writing the notes. And I had only one sister who was assisting me. And when the patient started straining on the tube, I removed the tube. After deflating the cuff, I removed the tube. But immediately after deflating the cuff, the patient and removing the tube, the patient vomited blood and aspirated blood. That blood containing vomitus, she aspirated, and she turned blue, blue black. And I was so stunned and I was so scared because the patient went into respiratory arrest, and I just I didn't think what to do, and I just picked the tube, whichever came in my hand. It was on the boils, and I passed the tube nasally because there was interdental wiring done, and I passed the tube. I did blind nasal intubation with that tube. I put in the tube. Simultaneously, I gave call to for help, and the hospital owner, he's quite senior surgeon, and he's a general surgeon. He immediately came for my help. Then the patient was resuscitated. We gave steep headlock position. We sucked all the vomitus, whatever we tried to suck all the vomitus which had blood, which had gone inside from the endotracheal tube. Then we gave steroids and all. And then the patient didn't go into the arrest, fortunately, because she was young. And then the patient, when the respiration was quite sort of settled, then we shifted the patient with the ETT to the ICU, intensive care. That hospital was having an intensive care unit, and we shifted the patient there. So, and afterwards, she was kept for on elective ventilation, and the extubated after some 2-3 no next day she was extubated, but she was there. She had a pneumonic patch, and that was with good antibiotics, and the rest of the chest physiotherapy, it settled.
So basically, ma'am, that means you kind of saved the patient during extubation. There was a large amount of bleeding which happened. There was a large amount of, you thought maybe the patient can be extubated, so you did extubate the patient, but then it led to a lot of bleeding. And then with your presence of mind and eternal vigilance, and also the quick hack, of maybe doing a blind nasal intubation. So this is where a blind nasal intubation helped her, because she was not able to see the glottis, it was full of blood, etc. And I think she'll be the best person to explain to us something about blind nasal. So, ma'am, I think you have a presentation on it, and you would like to show us.
Yeah. Thank you. Just briefly, I'll go through my presentation. I'll just share my screen. I'll try to share my screen. Just a minute.
Dr. Shiv, while ma'am is doing that, there's a question. If you could speak a little bit about doxapram.
Oh,
maybe 2-3 lines.
Yeah. Doxapram, we also call it a chemical stimulator. Okay, or chemical ventilator, actually, not stimulator.
I have never seen it. I've never used it.
Okay, I'll post something on it. Maybe like my short notes I posted, I'll post it on it, and I'll show some. I'll post some pictures as well. Doxapram. Yeah.
No, ma'am, we can't see your screen. Actually, I think you'll have to maybe your PowerPoint presentation.
Yeah. I'll have to.
पूरा off करिए, दोबारा से on करिए, then go back. Another question which has come, sir, which says that, do patients dream under anesthesia? Do you have any studies? Do you? So.
No, there's no study. There are patients. There are two groups of patients. Some of them will actually have completely normal kind of sleep, nothing. And there are others which actually come out. I've had patients who have actually said that, oh, I was having a meal. I was ready for my dessert and you woke me up.
Yeah, exactly.
There are. Yeah, and there are other patients. I mean, propofol actually gives a very kind of dreams which are actually not good.
Not good.
Yeah,
I had a very
No, I'm not talking about hallucinations. These are actually sexually oriented dreams.
Okay.
Yeah. And there actually was a case in which a young patient actually accused the anesthetist. Okay. And this happened very recently in the UK.
Okay.
And it was badly managed, and the anesthetist actually committed suicide.
Oh my God.
Yeah. So it's a known case. It's an Indian guy. And it was, even though it was proven that what she was describing was somebody different altogether.
Can you see my screen?
Yeah,
now?
It is trying to actually.
It is just trying right now.
Yeah.
Sorry? Yes, it's there. Yes.
Yeah. Yeah, sorry
Put
for
it on
the
PowerPoint, ma'am.
this is my I'll just go through briefly because actually
Sorry, Suchitra, it's not on yeah, you need to slideshow,
acha,
go on the slideshow.
yeah.
Yeah, next to it, next. That's it.
So actually,
Oh, you haven't. It's not still on. You need to click that slideshow. Yes. Now, yeah.
Yeah. Actually, discussing blind nasal intubation after discussing all the modern anesthesia is like going back to Stone Age era again. But such skills they never go. Actually, these skills they never go old, and some anesthetic skills we have to master, because in emergency, if you have not mastered those, you are not able to use it. Same applies with fiber optic intubation and phona also, because if you have not mastered those skills, although you are having a fiber optic bronchoscope with you, you won't be able to intubate the patient because you are not well aware with the cameras and all. So you have to master a particular skill if you want to use it in emergency. So this is one of the very important life-saving skill, because this skill doesn't need any gadget to use it. So what is blind nasal intubation? As the name suggests, it is a blind technique, but in anesthesia, there is no role for a blind there, as we are dealing with someone else's life. So you have to master this technique, and we have to go after careful planning. And it is blind because we are not doing direct laryngoscopy in this, and it is nasal because you are using the nasal passage for intubation. So it is intubation done by nasal route without visualizing the larynx by direct laryngoscopy. So ways or methods to do, there are two methods. We can, in anticipated difficult intubation, it can be done in awake patients using local anesthetics to attenuate the cough and gag reflex. And it is easier because we have the patient's breathing sounds to guide our tube. So it is a sort of easier method, but here the patient's cooperation is needed. If the patient, though you try to attenuate the reflexes, if the patient goes on struggling, gagging, then it is stressful for the anesthesiologist also and for the patient also. So patient's cooperation is needed, but it can be done under general anesthesia with or without the use of muscle relaxants. But before giving muscle relaxants, preferably they should be short acting like succinylcholine, and we have to ensure that the patient is getting ventilated properly with bag mask ventilation. Otherwise, then you don't go for the blind nasal intubation under anesthesia. So contraindications for this technique, absolute contraindication is only one if we are not allowed to touch the nose due to any reason. But relative contraindications can be injury to cervical spine, because for this particular intubation, we need a little bit extension at the cervical spine. The particular position may, so because of the fractured cervical spine, we may not be able to give that particular position, or we have to be very cautious about it. Then intra-oral pathology, which can read on touch. As it is a blind technique, while putting in the tube, we may touch that particular pathology and that patient may bleed. So if there is an intra-oral pathology, better to avoid. Then if there is a deranged coagulation profile, then also it's better to avoid, because if there is any inadvertent trauma to the airway passage, then that patient can bleed profusely. So why, if it is such a good technique, why we are not using it routinely? The answer is simple, because modern gadgets are available now. The modern gadgets like video laryngoscope, the fiber optic bronchoscope, all these gadgets are available freely. So it's better to have those. But in unanticipated difficulty situation, if you don't have those gadgets, then if you have this mastery over this, you can save the patient. On this technique, you can save the patient. This is blind technique, so always there is a chance of causing trauma to the vocal cords and other structures. So it is not practiced routinely. But I will suggest that to the new upcoming anesthesiologists, especially, this technique was taught to us in our days because that time this fiber optic and all were not available. We used to just rush for ENT posting, because this technique was taught mainly in the ENT theaters. So we used to, and our seniors were well versed with this technique. Nowadays, the teachers are also, they haven't used this. So maybe there is some hesitation, that also the litigation, if you cause a vocal cord trauma and all, then there can be litigations. So it's always better to put in under vision, a tube under vision. And but if you get a chance, I'll suggest that if unfortunately your patient dies, then you can practice on mannequins, no doubt about it. But you, to get the feel of the anatomy of the patient, you have to practice it on live patient. So better if, unfortunately, I may sound a bit crude or cruel here, but unfortunately, if your patient dies in the theater, you just don't let the body go unless practicing this blind nasal intubation technique. I will suggest that to the new anesthesiologist. Practice the technique in the life. Life means on the human bodies which are fresh. So actually, I'm very sorry that I was not able to download the video. I had posted it long back. Sir knows it about it, about the technique, which the post and the technique. So I have just, in this slide, I have given the link, and people can go through the link and they can go through the post when they have time. It is there on our the gas group. And I was it was not possible for me to actually to download the video. Actually,
that's fine. That's fine, Sujitra. We can actually give it.
Yeah, and there are many videos on the this thing also, internet, where people can watch the technique of blind nasal intubation.
Yeah.
So I think only this much on my side.
Sure,
There
ma'am.
was actually one good video which I wanted to show, but people can watch it later because we're already running short of time.
That is great, ma'am. We just wanted you to prime us regarding the blind nasal intubation,
Yeah.
Just as retrograde, blind nasal, scalpel technique, etc., etc. We just want everybody to know that all these techniques are available, and intubation and LMA is not the only two things which we are using.
Yes.
Yes. So I'll go ahead with our last case for the evening. Now, see, one of the dreaded complications of any general anesthesia is aspiration. And aspiration can happen anytime. It can happen at, during anesthesia. It can happen just when you're given anesthesia. It can happen during extubation. It can happen anytime. And it really points towards the importance of history taking to a large deal, right? So this is a case I'll just share with you. Yeah, so there's a middle-aged man who was taken up for an ortho surgery. Yeah, a middle-aged man who was taken up for an ortho surgery. It was double ortho surgery, so GA was planned, GA was given, and the surgery I think lasted for a really long time. This case was done by Dr. Chetna, so she would take us through this case. And so basically, Dr. Chetna, what happened at the time of extubation? This double ortho case which was done, GA was given, and surgery lasted for a long time. So if you could just tell us what happened at the time of extubation.
Thank you, Dr. Meenal, for the introduction to the case. Actually, this was a young male, very fit, ASA grade 1. The only thing was that it was a double ortho surgery. So we decided to go ahead with planned GA right from the beginning, rather than giving a block and then giving GA later on if required. So the thing was, patient was totally NVM. The surgery was planned for afternoon. Patient was NVM from morning 9 a.m. and surgery was in afternoon. And the patient extubation time was roughly around 7 p.m. So basically, a long time had lasted for NVM status if we consider. But still, at the time of extubation, when I had already given the reversal, when I had already deflated the cuff, I was thinking of just removing the tube. Just at that point, patient's all reflexes were normal, everything was completely fine. Just at that point, patient started vomiting, and it was thick food particles which were coming out, and it was a totally odd scenario. So luckily, since I had not extubated the patient, the tube was not out, it was just deflated. I just immediately inflated the cuff, and then I asked the assistants to give a steep head-low position. We repeated NSAID, we gave perinorm, and we started suctioning. But since it was a lot of food particles which were coming, so we put in a thick rise tube, 18 gauge, and we started suctioning through it and also through the oropharynx. Both suctionings were being done. I took 2 suctions separately. It was available in the operation theater, so I used both the suctions separately, and suctioning was done. And and I checked the respiratory system. There was no aspiration in it. Patient was perfectly fine. Saturation was well maintained. There was absolutely no problem with that. So only after all the food particles had been suctioned out, it was clear that he doesn't have anything more. Rice tube was removed. Oropharynx was checked again for any remnant of food particles, and the patient was comfortable. Only then I extubated the patient. So this was, even though we had taken a proper history of NDM and everything, this had happened in a young male with no history of like diabetes, which can cause gastroparesis or any other causal factor. So after extubation, when patient was being shifted, I again confirmed the NDM status just to be on the safer side. So they said, yes, patient was NDM from 9 a.m., but he had taken 5 puffs in the morning before surgery, before the NDM started. So that 5 puffs were not digested till 7 p.m. So this vomiting can occur at any time, and we should be prepared for, especially during extubation, for such things. Suction should always be ready, whether intubation time or extubation time.
Right. Thank you so much for sharing your one second. Thank you so much for sharing your inputs, Dr. Chetna. And actually, I would say that yeah, you said very rightly that suction is the most important thing you're in this. But whatever, your presence of mind, whatever you did, little things you did, be it head low, these, I would like to say to all the freelancers, especially, these might appear very small tips, but these are the life-saving tips actually. Checking for suction most important before you start a case, because it can happen anytime. It can, and you see, the patient never expected. The patient was long surgery, but then this again happened. Yes, ma'am, you would want to add something.
Yeah, just only one point in, actually it's a small point, but it can be helpful to the new generation. In that particular patient, I did not charge anything because that girl was actually without parents. The surgery, the cost was bear by her brother. And when the ICU was extra burden to them, so I requested the institute that whatever was the extra burden of the ICU, please you give to me, I'll bear with that. And but institute was kind enough, and they did not charge anything extra to the patient. These points we have to talk, because many times, yeah, there are very,
I think these are very practical points, because we get a lot of knowledge from Millers and from Morgans and everything.
Yeah.
But man management, at least knowing how to handle people, communication skills, all these things we learn only when we are on the job, and which is, I think, more important to be, a good anesthetic, a good human being, than just to be a good anesthetic. That is more important, your skills, all of them. Right. So my question to Dr. Soma would be regarding this case. So are you there?
Yes, I'm here.
Yes. So, of course, we know that she checked the NDM status multiple times, and yet, there was no history of any gastroparesis. So, could you take us through a few conditions where we must keep in mind that what can lead to delayed gastric emptying? Certain conditions which you can just tell, kind
of. Any patient who is undergoing surgery will have an anxiety. So, pre-existing anxiety is one of the reasons where the gastric emptying is going to be delayed. And moreover, if we are going to treat patients with drugs such as opioids for a perioperative analgesia, then they are at risk of nausea, vomiting, and at risk of aspiration, along with decreased gastric emptying times. So, and if patients are already having a history of GERD or reflux esophagitis, or the patients have been given non-steroidal anti-inflammatory drugs where there is an gastritis and reflux because of that, then these are certain conditions where we need to be very careful while extubating. I fondly recall an incident during my residency. So there was a patient, for a young patient, some 6 or 7-year-old child, for some cleidocranial anomaly, for some spine fixation cervical region. And as soon as the patient, we have induced the patient, and then we have ensured that the patient was NBM in the ward. The sisters were monitoring, and from the mother and everyone. As soon as the patient was induced, then there was a whitish solid substance that's coming out. And then but luckily my professor was there, then we managed to secure the airway immediately, inflate the cuff, and then we put in a Riles tube, given an, actually we gave a gastric lavage, and then we removed the gastric contents, and then we did that. So this is one of the most common scenarios. The patient's relatives think that the patients will undergo prolonged surgery, and they may will be NBM, and they may have some problems. So such psychological issues. Then one another incident wherein intensive care unit, there was a tribal patient who had a postpartum hemorrhage and was on ARDS for a prolonged period of time, almost for 75 days was on ventilator. And then the patient's mother used to come and see. She was a very typical tribal woman. She used to believe that if nothing goes by mouth, the patient will die. So every day, if the patient was on initially on endotracheal tube, then she will feed the patient, put all the bread and everything into the patient's mouth, and then silently, after covering, in the pretext of giving care to the patient. And after tracheostomy was done, then she will actually stuff the patient's mother, and we had to literally ban the patient's mother from seeing the patient so that we can give a care. Or we used to have a staff nurse standing by the patient's mother without touching and all. So in this, I think in this scenario, even though the patient had, the NBM was confirmed, I think the patient had food, and then it's one of the patients, one of the situations where patients conceal the history that they had food or liquids before surgery. And the anxiety, right from induction throughout to extubation, even neostigmine is known to cause reflux, and the patients can aspirate because of that. I follow what Dr. Shiv has told long back in the group, like with an dexamethasone prophylaxis for post-op nausea vomiting, as even before induction, and then if the prolonged surgery is going to happen, we give ondansetron before extubation, at least 15-20 minutes before extubation. So most of the times this will take care, but in such situations where Dr. Chetna has faced, I think she did a right job of managing the patient effectively without aspiration. So this Mendelssohn syndrome, if it happens, and it has drastic consequences. In my experience, I've experienced one case of Mendelssohn syndrome where we had an exploratory laparotomy, and patient aspirated the gastric contents. It was a gastrocolic fistula. It was a fecal matter that was aspirated. And then we lost the patient. I think this happened this happened during my residency, actually. So that was the only experience of Mendelssohn syndrome. Within moments, we can see whatever the hemodynamic parameters, the respiratory changes. We did tried an bronchoalveolar lavage with a fiber optic scope, and did lots to save the patient, but then ultimately we lost the patient. So I think Dr. Chetna did a good job of saving the patient's life. So it all brings down to the eternal vigilance, which an anesthetist is perfect to play the role, and the role of situational awareness, as with difficulty airway. So once we are aware of the situation where we are in, and then with our calm mind, we can manage the situation in an effective way. Thank you.
Very, very well said. We have a very active audience on YouTube, which is also telling us that the anesthesiologist should have the remote control for everything which is going on. And that is great, yes. And one little thing I would want to add here is that, when I was doing my residency, one of my consultants actually, he had a small baby who was taken in, and I confirmed a number of times, NBM status was confirmed, but then the same thing happened, aspirated. And I remember my consultant actually literally, turning him upside down completely. So sometimes, we have to actually resort to extreme measures to save patients, whatever it takes to save them, be it any skills, be it anything, calling for help, etc. So, Dr. Raghavendran, do you have any other pointers to add? And then we can finish with the DAS extubation guidelines.
Okay. See, as far as the fasting is concerned, nowadays, we have started allowing up to about 2 hours clear liquids. And contrary to what people may think, this clear liberal fluid intake up to 2 hours actually helps in peristaltic movements and reduces the stomach content, and also increases the gastric pH. So this is what we started following in our institution. Of course, the protocols for the solids always remain, and we follow the same protocol as such. And regarding the aspiration thing, what is mentioned is that the solid aspiration, solid contents is much more dangerous, contrary to what people may think, because when you aspirate liquids, unless the pH is below 2.5, there's not much of a problem. See, if you aspirate bile, it's not going to cause much of a problem. Patient will have some bit of lung signs, but they'll come out of it. But then, unless the pH is below 2.5, and the content also important. See, it has been more than about 25 ml to cause a lot of damage. So the chemical immunities is not a problem. Many times we see patients aspirate, but then they're not really troubled much by it actually. That's because of the gastric the content as well as the pH. So, and other thing is now um, in susceptible people where you would think that they may have aspiration problem like say GERD, obesity and all, then you have to put them on prophylactic measures like PPA, proton pump inhibitors and H2 receptor antagonists and gastric prokinetic factors. So they all help to reduce the, whatever the impact of the, even if it occurs, it helps to reduce the, the damage which can occur. And steroids don't have much of a role if in an established aspiration pneumonitis. And ARDS has to be managed as per protocol, and we have to sort of transfer patients to ICU once a full-blown ARDS occurs. And I remember when I was doing my residency at Satyajit Hospital, we had a patient, difficult intubation case, and then multiple attempts by multiple people, and she did aspirate, and short stature lady actually. Finally, our professor came, and then he was able to put in a tube. But the patient had a full-blown aspiration, and then the child survived, but mother did not. So these are things which can be quite a deadly complication, and then you have to anticipate for such events, and then see if you can. Prevention always better as far as aspiration is concerned.
Yes, I think extremely important for everybody to know that now the clear liquids and what are clear liquids. Please, whoever doesn't know what are clear liquids also should read up about it. What is clear liquid? The juices, etc. Are they clear liquids? Are they not clear liquids? Please read about it because this is out of scope of our discussion actually here. And there are so many other reasons for actually having delayed gastric emptying. CRF, trauma, opioids, so many other things, old age, etc. So we have to keep everything in mind. So now with all of this that we have done, I would now like to hand over the final part of the presentation to Dr. Shiv. Before that, just a second, sir. Yeah, so takeaways from this case was NDM history is very important. You know, delayed gastric emptying, you must know what all are the reasons for it. High index of suspicion. Always keep a working suction near your head end ready. Not attaching, different kinds of, sometimes the suction, the tube which you're using, we are cutting it from places, and then I see a lot of freelancing places, कुछ करके भी तो वो एक हम लोग बनाते हैं. So you have to be very careful of all these things. That much time is lost, and choose your anesthesia extremely wisely. So with this, I would like to come to the difficult anesthesia extubation protocol, sir. If you could just take us through it. Sure, sir.
Before I think I start that, I'll one of the things in Chetna's case is what patient has actually eaten, and we all know that anything which is fatty, okay, is actually digested very slowly. So having puffs which is actually full of fat, actually it is actually made of. I mean, if you look at the amount of oil is there in the puffs and things like that. So those are actually equally important. So, and that's why I'd say that when patients are actually told to eat in the morning, they usually said something light. Okay. So this is something light is basically something which is easily digestible. And best thing is obviously anything they can actually have sugary drinks which actually is helped. So this is actually part of our protocol. Some of the patients are actually told that they can actually have something which has got, sugar, unless obviously they're diabetic. But that's, and hydration. I think more than hunger, it is a hydration, especially in India, especially summer times. If you can actually allow them hydration, then the people can actually Got it. I mean, a lot of Indians keep that breath, isn't it? They don't
Fasting, yes,
drink.
yes.
So it's
Fasting is
so for a surgery, I think one day you have to explain to the patient. You say, "आप व्रत तो रखते हो ना? So why don't you actually do this for a day? Like understand the difference, understand what risk you can actually face." Okay. So with this, we will actually go on to the extubation guidelines. And I will be talking mainly about the difficult airway guidelines. So when you actually have a difficult intubation, you should expect that the extubation can also be difficult. And the fact that you had difficult intubation, it leads to trauma. Trauma leads to edema, and edema can lead to life-threatening airway obstruction. Okay, so how quickly the glottis actually becomes edematous, you'll be very surprised. Okay, so it's important that there is safe extubation actually followed. So the Difficult Airway Society came up with these guidelines, which actually basically goes from the 4 Ps. So you need to plan extubation, you need to prepare for extubation, then you obviously will have to perform extubation, but in a safe way. And lastly, what about the post-extubation care? Are you going to just send them back to the ward? No, you're not. They need to be observed because things like said as trauma has occurred, trauma can occur during intubation, extubation, and airway does swell up and that cause problems. So the patient need to be actually monitored in a HDU or ICU kind of setup. So planning, we have that basically you assess the airway and you look at the general risk factors. And obviously the main thing is that the difficult airway was difficult and thus you faced difficulty during that situation. But you can also actually have patients who might actually have, even though the intubation was easy, it could be patient with say obesity with a obstructive sleep apnea. Now, those patients you need to be careful because you can have obstruction from the residual anesthetic opioids. Okay, so those things also come into picture. Or patients who are at risk, we just talked about them. Patient having hiatus hernia or having the GORD, okay, special reflux disease. Okay, those patients are the high risk patients. So you prepare, and in this case, it's about optimization of the patient, and then the patient have to be ready to be extubated. So that is a common thing everybody knows. If your patient has had a long surgery and lost a lot of blood and is acidotic, you're not going to extubate them. So they will be actually then shifted directly to the intensive care where they'll be extubated after optimization. So in this, they have divided patients into low risk and a high risk. Okay, and then we go into these two algorithms. So low risk algorithm and high risk algorithm. So the first one is the low risk algorithm. So you actually identify the patient, you have prepared them, and now you actually have two options. Okay, so do you have the patient awake extubated? That's pretty safe in certain situations where you have upper airway surgery. You want the reflexes to be present because there is high risk of aspiration. Okay, those things are simple, but one thing you have to remember that when you are trying to actually have patient awake, they can do one thing, and I did talk about it. It's about that they can chew on the airway, and if the patient actually bites on the airway, in a situation like that, then this can actually lead to negative pressure pulmonary edema. So you need to actually have a bite block or a Girdle's airway in the mouth before you extubate them awake. Okay, not a nasopharyngeal airway. You need to have an oropharyngeal airway or a bite so that patient doesn't bite on the tube. The patient is actually reversed. The patient is trying to breathe and it breathes against a closed. It's just like laryngospasm. Okay. So laryngospasm, the glottis closes and patient's trying to breathe. Here, the patient is, biting on the tube, nothing goes in, nothing comes out, and they go into pulmonary. And then the other thing is, do you want to have a nice, smooth extubation? Then it's deep extubation. And deep extubation is a kind of a more advanced technique, and this is not something which first year postgraduate will try to do. You need to have experience to this, and a lot of vigilance is required. There are different ways of doing this extubation, and I will likely talk about them in a minute. And so awake extubation, this is the protocol. Okay, so you need to position the patient appropriately, sit them up. You need to have assistance. Make sure there is nothing in the airway. So one of the commonest thing which initiates laryngospasm in it. Now, if you are waking up patient deep, so there is always a residual anesthetic. So anything which stimulates or irritates the airway is going to cause extubation. Cause laryngospasm. Okay, and like I've said, you need to have airway adjunct, have a bite block, okay, like a roll guard. You can also put a oropharyngeal airway, like a Goodell's airway, along the side of the tube. That's also possible. You sort of denitrogenate so that there is a good amount of oxygen within your functional residual capacity. You make sure the patient is cardiovascularly stable, and there is good gas exchange. End-tidal CO2 is there, is properly reversed. Patient is okay, and there is adequate analgesia. Now, this is kind of thing. Would you actually give them something before it? No, I think you have to have a balance that there is analgesia from the surgical side, so patient doesn't wake up, in severe pain and then cause problems. And so this is patient is awake and opening eyes, obeying commands, and then you apply positive pressure, deflate the cuff, and remove the tube in the expirative phase. When patient is trying to breathe, the vocal cord, expiration, the vocal cords are fully open, and then you actually take the airway out. Okay. And you ensure that airway is patent. You continue giving oxygen, and then it's about safe transfer. Now, with awake extubation, the patient is actually better than deep extubation, where the patient still have the residual anesthetic. So you don't want that. So awake extubation, everybody does it regularly, but I mean, there's a certain kind of protocol you need to follow. Sit them up. A lot of people actually forget to actually sit up the patients. Simple as that. And the other is basically where the second part of it. So this is high risk patient. So this protocol is actually followed. And so one part is, yes, you can actually, it's safe to extubate, and we talked about awake extubation and deep extubation. But if it is not safe to extubate, now these are high risk patients, then you need to postpone the extubation. You say, no, we're not. Now we are talking about patient might be cardiovascularly unstable, patient might be metabolic derangement, so patient is acidotic, or there is some issue with neuromuscular blockage. Say, for example, the patient has got sucks apnea. Okay, so in those cases, you can actually think of that. And very rarely, you might actually think that, you got airway surgery, which was the head and neck like kind of operations, which are very extensive. They're going to be airway. In those cases, tracheostomy is done as a routine. Patients actually have tracheostomies, and but you still need to actually send them to the HDU for monitoring. Okay. So the other things about deep extubation, we talked about awake extubation and coming to the deep extubations. And one of the techniques is to actually use something called Bailey's maneuver. You can actually see that the patient has got endotracheal tube, and there is a supraglottic device as well. Here it's an iGel. So you actually have the patient, you bring down you reverse the neuromuscular blockade. You have the switched off the sevoflurane, isoprene, whatever volt anesthesia you're using. Okay, once they are around probably 0.3 Mac or so, or 0.4 Mac, patient still sleep but still not waking, you can take out the tube, or even you can take it out even at 1 Mac. It's not a problem. Because you can actually switch off the volatile anesthetic once you have reversed the patient adequately. Good tidal volume breaths are there. Patient is generating good tidal volume, so you can take it out, leave the iGel or the any other second generation supraglottic device, and let them wake up with a supraglottic device. Sometimes patient can take the airway out yourself. Advantage of the eye gel is that it's got its inbuilt bite block, so they cannot chew on the tube, so they cannot cause negative pressure from edema. Someone mentioned about dexmedetomidine. We don't have that much of experience with that, but that's another thing. But with remifentanil, you can actually start them on, target control infusion, and it said that around 1.5 nanogram per ml concentration will actually allow you to extubate the trachea with ease. Okay, and again, it's got a short context sensitive half-life, so within 3 minutes, everything is washed out. So a great, unlike the dexmedetomidine, there is no residual effect of remifentanil. Then there is something called a stage extubation equipment, and which can be used. And I did actually have this, but I think it looks like I took it for the Airway workshop to Hyderabad, and I think left it there. I just couldn't find it this morning. So this is a soft catheter. So it is a ventilating bougie, but the purple part of the bougie is actually very soft. It has a long guide wire. So what is done is basically on the right side, that is a guide wire, and that can be actually left in. And patients tend to tolerate this guide wire. Again, guide wire actually got a soft, the first part of it, which goes into the trachea, is very soft. Patients tolerate it very well. And now if there is a problem, you can thread the catheter in. Okay, exchange catheter over the guide wire, take out the guide wire and use it as a bougie. So this is just a soft bougie you can actually use. And then again, they come with a rapid fit connectors, which can connect it to the bougie and ventilate if the patient is desaturating. So this is part of a staged extubation equipment. You can leave the guide wire in, let the patient wake up. If anything goes wrong, you thread the bougie in, and you can railroad the tube. So very safe thing to use. Okay. And that's the end of the today's thing. I will actually hand it over back to Meenal to end with the ceremony of closing ceremony and thanking everyone. Over to you, Meenal.
Yes, sir. So I hope all of you actually enjoyed this session, because I enjoyed putting it all together for each one of you. I think so. Even till the end, we have quite an audience who are still, asking us so many questions. So I have one question. Anybody can just take that question, and it says that. Okay, so before I do that, I'll just finish off with this presentation last part. So you see the slide. Anyway, we are blamed for everything. The anesthetists are blamed for everything. Delays in DOT, bleeding, global warming, everything. You name it, and we get blamed for everything.
Yeah, not having
right?
coffee.
Yeah, everything and anything on the list comes. So at least I feel that the least we should do is to have those tricks up our sleeves. Have know those basic hacks, update our knowledge, keep attending these seminars, and no matter how much of an airway you have done, it's never enough. I forgot to tell one thing, when I was discussing about the stages of relationship, just the stage of relationship between us and the airway, that those stages are never fluid. They don't happen one after the other. Somebody who's worked a lot with the airway can also get back to having a very difficult airway, not able to intubate, get stuck, and okay. But the only thing which differentiates him from the others is that he has those, he's using his skills, he's using those protocols, he's practicing them. As Thomas said, please, airway access. And as Suchitra ma'am said, though it is, ma'am, it's actually, I had chills, when you said that if something happens to the patient, still practice blind nasal intubation on the OT table. But then, yes, how else are you going to learn? How else are you going to know that, who is, so it is very, very important for all of us to rise up to the occasion. And for that is the reason we have such groups, we have such learning sessions. We may have long discussions, but nevertheless, please watch it, because we have got them all together for you. And in the long run, I realized I learned so much when I was gathering these cases. A big thank you to all the presenters, Dr. Dilip, Dr. Jayal, Dr. Anwar, Dr. Chetna, Dr. Suchitra, and also to those who did not want to be named, but they did, they, on conditions of anonymity, they gave their cases. Thank you so much. Because of whatever you shared with us, we became little wiser today. Thank you. And to all the panelists here for giving 4 hours to us, and they have done proper homework, they've written down points, they've made presentations. I think it has been it has been a conference by itself. Today's day has been like a conference. Dr. Raghavendran, Dr. Suchitra, Dr. Soma, and of course, Dr. Shiv. I think all of us can't cease to thank you enough for this excellent group, which gives us the opportunity to express and write and talk and comment. But there's one thing I would like to also mention here, that we have to be a little, I think maybe careful when we comment on somebody else's cases on on Facebook. Be a little generous. Maybe you have not done it the way you think it is, but then whatever you think is not always right. There are always many ways of doing something. There are many people who might get offended. There are many people who don't want to share, because this is what came across. When people actually were calling me and giving me cases, they said, no, don't take our name, just present the case, because they were scared of being scrutinized. So, this should not happen, because these problems can happen with any of us. It can be with the best, it can be with the worst. So, thank you so much. And yeah, so I will end with this one question. Anybody can take it. That is that if there is a bleeding which has happened, maybe in tonsillectomy, etc., there's a small baby and you've taken a tonsillectomy case. Post-extubation bleeding has happened. Now, in adults, we are able to do retrograde, we are able to do airway block. What do you do with a baby? So this is something I know, but I would want all of you to basically answer. Anyone can take it.
Dr. Raghavendran will be the best person, because a pediatric case, I think he would be the best person to take this question.
Yes.
Mic off, please. Sorry, it's off, Dr. Raghavendran.
Yeah. I didn't quite get the.
The question is, sir, that if suppose there is a pediatric patient who has undergone tonsillectomy, okay, and then if post-extubation the patient starts bleeding from the tonsils. So like in adults, we are able to do retrograde intubation, we are able to give airway blocks, we are able to salvage the situation. What do we do in such a small child?
Well, actually, in a child, we had to consider the child as a full stomach, because child would have sort of swallowed a lot of blood and also would have lost some blood. And depending upon the amount of blood loss, probably there is going to be some amount of some disturbance also, hemodynamic changes. But actually, the priority is sort of get the child under anesthesia, and then go for something like you have to take risks such cases. And I don't think you can put in a rice tube prior to induction, because child won't tolerate it actually. So go for a crash induction, and that's how we always go for the go for a crash induction only, and then use some safe drugs like ketamine, which will not depress the circulation much, and then rapid acting. And then if the intubation was not difficult, then you should not have much a problem in putting a tube. But you have to sort of the priority is to stick the child as soon as possible. And then the problem is that if you reverse the patient, that patient may be under influence of the anticholinesterase and all. That has to be taken into account, but usually not have much of a problem. So you can probably give again some succinylcholine and get the intubation done in such patients. So the thing is, it's and sometimes you have to even look for take a sample for cross matching as well as for coagulation defect. Sometimes we have seen some children. I have had a case where a child came back repeatedly for some 6-7 times over a period of about 3 days. And finally, we found that it's a male child, and then we found that child was having atypical hemophilia. So that led to the post-op bleeding and all. So it was a day and night, and they had to keep on coming day and night all at 6 hours intervals now. So 6 or 7 times anesthesia for the child. Okay. So somehow we could save the baby somehow. But every time it's a crash induction, and then we just take the sample for whatever, and then we had to arrange finally the cryoprecipitates and also the factor eights. Then the whole thing subsided. At one stage, we were thinking about going for external cardiac ligation also. So these things happen now and then.
I think we have lost Mino here. I think this problem, like she said, the electricity actually goes off. So she might actually just.
Can I add something?
Yeah, Dr. Dilip.
I had a surgeon who was unable to put a tie inside the oral cavity while doing the tonsil. So 2 cases I did, then I said, sorry, I cannot assist you. He's a good friend of mine, but then he did not know how to put a finger inside and take the knot down the space where it is bleeding. And then another person was not ready to do minute coagulation, because I had seen people that started using the cautery. I advised him. So these 2 persons I avoided. That is the only way. Otherwise, a child and then bleeding coming up on table is a private practice, is a very big disaster because there is no help available.
Yeah. So this is actually a common question actually asked in the exams. It's a common final FRCA question for pediatrics. Bleeding tonsils is a common question, a very common question, and it's all about I think being practical, where you have to say that you have to assess the patient cardiovascularly as well. The patient is bleeding, they can bleed significantly, and last thing you want is actually give an anesthetic agent which is going to cause a severe drop in the blood pressure and patient actually. So resuscitation, making sure that there is IV line is there, there's blood there, there is fluids going. These are equally important part. And there is no other answer to is that you have to actually intubate the trachea. There is nothing else. This is here, you're not, obviously, unless there is, you find difficult in getting the tube in, you're not going to go for tracheostomy or retrograde or blind. This is nothing. It's simple, straightforward, the induction agent followed by muscle relaxant, laryngoscopy and tube. And in kids, in the kids, succinylcholine and good dose of atracurium works the same way. They work as quickly. In our older age children's hospital, the drug uses atracurium in good dose. They don't use succinylcholine most of the times.
And best part with tonsillectomy is we have the ENT surgeon with us. So if there is any complication, actually he is well versed with the airway. It's with the more than the other surgical people. So
I think I had taken up 1 or 2 cases with post-op bleeding with head low suction ready in surgeon center, and then before giving scoline, I gave the suction, and then immediately before intubation also with suction. I think 2 cases I had done. That was the only thing, Pento and scoline.
Yeah. Once actually I actually had a case where ENT surgeons, which they were doing a tumor in the oral airway, and they just bled like hell before you've got a tube in. I don't know. I don't know how I managed to actually get a tube. And I was this is when I was in AIMS as a registrar, and I just don't know how I actually got the tube in. I felt great that day. So this kind of things happen, but there are also there where they say that you actually get a surgeon to put their hand in and put a swab in the tonsils, and while you do a laryngoscopy. So there are different ways, and I think one important message which one second, I just wanted to add Mino, is that people are sharing their cases. I mean, Jael has shared a wonderful case on the thing, and yes, people need to be considerate about people sharing. First of all, I think they have been very courageous. They've been very courageous to actually share the case, because when you actually share a case, you know that you will be asked some difficult questions. and there will be people who are ready to criticize. Okay, however good you do things, there are always people trying to find negative things. And I think other people also should actually add, and if somebody actually trying to be nasty, go and give them a dose. Do tell them, they say, calm down guys. Calm down. You haven't been in his boots, so you do not know what he has been through. I think he'd be commended for sharing cases,
Yes,
because there
yes.
is always a learning. We can never be 100% perfect. Somewhere we will actually make a mistake, and that's where we learn from. So I
Exactly.
think
I
sorry.
would also want to say here, sir, that people, who had shared their cases on, reasons for anonymity, I'm getting messages saying that thank you so much for putting across whatever we wanted to say
Yeah.
with a lot of grace, and we never felt we were being dissected. So that
Yes.
is a great win, sir, for this, I think.
Yes, absolutely, absolutely. And Soma has actually joined back with this video, so we'll add him to the spotlight as well. Yeah. So I think thank you. I think to all of you, and for such a wonderful. I think session series one actually has gone really well. People have actually learned probably a lot, taken back some messages. We can share some of the things like about safe extubation, laryngospasm or bronchospasm protocols. We have done it many times, but it's always nice to just keep repeating things. And I will actually also try to see if I can actually get a video of the unanticipated difficult airway done as a simulation, because we do actually do simulation in simple simulation in our setups. We do it for the surgical on a surgical courses as well. So it'd be a nice video to just do that. And I think repeating this again and again actually is very, very helpful. I will actually stop the sharing on the YouTube.